Well, good morning, everybody, and welcome to the Health Scrutiny Committee, the first Health Scrutiny Committee since the election. We'll go through a few items on the agenda, and then we have some visitors with us this morning. But first of all, we have to look at agenda item number 1, which is to appoint the chairman, which is myself, of this committee, and Councillor Matt Barney, who's sitting to my left, as vice chair of this committee. So that is the first thing on the agenda. Can we just have a show of hands just to show that everybody's in favour? Thank you. Now we move on to the item number 2, which is membership and terms of reference. Now, if you look at agenda item number 2, there is a list of the people on this committee. And in a few seconds, I shall ask if we can all introduce ourselves, because we have a lot of new members and we really want to know who we're talking about. But if we notice in point 3, just, yes, David. Oh.
Let's just pause for a minute then, Chair. So
yeah.
Do anything.
Has he? Oh. There are a lot up there, are there? I can't see them. Are there a lot up there, David? Oh, right. Well, we'll wait. It's not working up there.
Is it? So students giving me a thumbs up, Chair, as if they can hear now. So now Noel can just come back and figure it.
Here anyway. Thank you. I'll just wait for you to get back to your seat now. Right, so moving on to item number 2 on the agenda of 3. We'll introduce ourselves in a minute, but I just want to say that the point of this committee is the responsibility for scrutinising health matters in relation to the service provision for residents throughout Nottinghamshire. So we are here for our residents. We are in all committees, but particularly in the health scrutiny, because we're looking at health, which applies to everybody in the county. So just moving back, we've got all these new members. So should we go around and introduce ourselves? I think you know me now as Sue Saddington, and my vice chairman is microphone.
Can I just say to all new members, if you're not familiar with the system, you need to hit the button at the centre of your microphone. You'll see there's a little graphic of a man speaking. The top of your microphone will illuminate, and if you can make sure you turn it off afterwards so that the next person can speak.
Illuminated and understood. Thank you.
I pressed it. Yeah, it did that. And then, right, it's on permanently now. It's playing games. Councillor Mike Adams, anyway. Nice to meet you all. Thank you.
Oh, there we go. Hello.
I'm Councillor Martin. I'm the Selston Division in the west of the county in Ashfield.
Don't forget to use your microphone, Councillor, when you're speaking.
I'm Councillor John Wilmot from Hucknall North, representing the Hucknall North people, and I am a member of this committee, even though it doesn't say so on the
Well, welcome.
Script.
Welcome to the committee.
I do apologise, Councillor Wilmot. That was my error.
Councillor Well.
Councillor Michelle Welsh for Arnold South.
Thank you. Okay, we've heard you. Councillor Bailey.
Oh, is it working now? Councillor Bailey works up north.
Councillor Eddie Cubley, Eastwood Division.
If his microphone works.
Thank you, Chair. Martin Gately from Democratic Services, the Lead Officer for Health Scrutiny.
And I'm Noel McMenamin. I'm the Democratic Officer for this particular meeting.
Hello everyone, Ajanta Biswas, Vice Chair, Health Watch Nottingham, Nottinghamshire.
No, sorry, Chair. No, I did send my apologies in for that, didn't I? Yeah.
No apologies received.
Just to say that I'm a committee member of the Wyburn Medical Practice.
Thank you. You got that? Yes. Michelle.
Yeah, I've been advised that I need to make it quite clear that I had a baby 14 months ago in an NUH hospital. So I just wanted to make that quite clear with regards to that.
Councillor Gowland, did you want?
I work in medical research and I work with NUH obstetrics.
Councillor Barney.
And just in light of item 7, the diabetes services, I declare that my daughter, who's 12 years old, is a beneficiary of the Nottingham University Hospital's diabetes services. She's a type 1 diabetic.
Thank you. And I have a personal declaration to make because my daughter works at Queen's Medical Centre and she is a diabetic paediatric specialist nurse. So although it's not on the agenda for children today, she is actually in the unit. So we can move on now.
Chair, sorry.
Oh, I'm sorry.
No, you're all right, Chair. No, my daughter's a nurse as well, so.
All right, thank
you. My daughter's a nurse at Queensmad.
Thank you, that's noted. Thank you. I think we'll all end up giving declarations. Right, so now we're very fortunate today to have the return of the staff from University Hospital with regard to the medical services. We have Dr. Keith Girling, we have Michelle Rhodes, and we have Carol Drummond. And I'm going to leave it to them to make their formal introductions to us. But welcome to all three of you, and thank you very much for coming to see us. So would you like to just introduce yourself? Start with Dr. Girling.
Thank you very much, Chair. So I'm Dr. Keith Girling. I'm the Medical Director at Nottingham University Hospitals.
Thank you.
Hi, I'm Michelle Rhodes and I'm the new Chief Nurse, Day 6 at NUH.
Is yours not working? That's it, you're in business.
I'm Carol Drummond and I'm the Interim Director of Midwifery at NUH, been there since February, and the permanent person will be joining on the 21st of June, just for your information.
Thank you very much indeed. So I'm aware that you've been here, I think, twice before. So what I wonder, Dr. Girling, before you speak, is could you just update the committee on where we are today? We do all have a brief before us, so we know exactly why you came in the first place. But if you would just not mind giving us a short brief so that the new members, which is all of us except Councillor Martin, could just get focused on what is to date. Thank you.
Thank you, Chair, and thank you for having us back to the committee. As you say, Sarah Moppet, the then interim chief nurse, and I attended in March of this year to provide the most recent update on the NUH maternity services. And Council well be aware that there have been some long-standing concerns about maternity services at NUH, which despite previous interventions had not improved. A situation that came to a head in 2020. There was a high-profile coroner's case, which resulted in a narrative that the neglect right and a preventive deaths report. We also had some concerns raised by the Healthcare Safety Investigation Branch, and who's culminated in a visit to the Care Quality Commission in October last year, where they rated our maternity services adequate. The response from the organisation was to put into place a maternity improvement programme that was building on a transformation programme that had been started earlier in the year. And there were a number of elements to that programme, 5 work streams, each led by an executive director. Since the programme has been in place, and to update on some of the details in the report, which was submitted about 3 weeks ago. I'll go through them step by step, but in staffing terms, staffing was a key concern from the CQC, and we have importantly recruited, as you've already heard, a substantive director of midwifery who'll be starting later this month. We have been extremely grateful to Carol for her time with us as the interim director of midwifery, and Carol has brought a very significant experience to the service, and she can describe more of that if that's helpful. And I'm pleased to report that we have made a number of appointments into the midwifery since September of last year. So between September and now, we have appointed 39 additional midwives against a previous gap of 61. We have offered jobs to a further 58 midwives who would be expected to start between now and the end of October. However, movement of staff is such that even with those appointments, if all of those people that have been offered jobs will commence as expected, we will still be left with 16 vacancies by the end of that period. So Michelle, in her first week, and Carol have been working with other local providers, in particularly Sherwood Forest hospitals, to look at recruitment opportunities that we may be able to work together to meet that gap. And Michelle and Carol will be in a better position than I to describe the detail of that. In addition to the midwifery staffing, we have also approved 6 new consultant posts, 3 of which are currently out to advert, and 3 of which will be later this year. And these appointments taken together would move us in the right direction for the staffing of the unit and take us towards the standards that are expected, not just for the maternity improvement programme from the CQC action plan, but also towards the Ockenden standards. And I'm sure councillors will be aware of the Ockenden report into maternity services nationally and the expectation that each trust meets those standards. We have continued with daily multidisciplinary team meetings for safety, and those meetings are well attended and well received by staff who feel that they are able to raise any concerns that they have with staffing or with equipment or other issues on a day-by-day basis to make sure that our units are as safe as they possibly can be. The CQC raised significant concerns around our fetal heart rate monitoring. The so-called Ctg, the cardiotachograph, is a way of measuring the baby's heart rate, and there was concern from the CQC and from the Health Care Safety Investigation Branch that we were having incidents related to the inaccurate interpretation of CTGs. We have completed training for all staff of all groups, consistent with the national training recommendations around Dawes Redmond packages and K2 training packages, which would be consistent with every other service in the country. We have, in addition to that, undertaken competency assessments for all of our staff, and as we speak today, 100% of consultants have completed that competency assessment and passed, 92% of trainees and 86% of midwives. Our target was to hit 90% of all staff groups, allowing for the fact that we have a proportion of staff on long-term sick and on maternity leave. So we are just short, in fact, 17 midwives short of the competency assessments. We are working hard, and again, Carol will be able to fill in the details, to complete those competency assessments this week or next. In addition to the interpretation of the CTG, the CQC were concerned about the availability of machines, CTG machines, the monitoring devices. And at the end of the last financial year, we were able to put in a procurement order for 51 new CTG machines. We weren't 51 machines short. We have a rolling programme of replacement, and part of that order was part of last year's rolling programme of replacement. Part of that order was this year's replacement programme, and part of it was some additional machines. All of those machines are in the trust. Additional machines have now been deployed after training to the Queen's Medical Centre. 15 are now in place of those machines as extra machines. And there are 25 machines ready to be deployed into the city site. As of today, we would only deploy those machines once 70% of staff have had the training on the new machines. And as of today, we have just over 60% of staff trained, and so we are looking to complete that training this week. So the expectation to have that completed and in place by the end of May has been missed. The CQC also raised significant concerns about our digital availability of equipment and of the electronic patient record being inconsistent. So we had different systems working in the community from in the trust, and those different systems weren't able to communicate together, meaning that information was delayed in getting from community services into the trust. And from the beginning of January, we have had a common electronic patient record through the Medway maternity system, which the trust has been using for a number of years, but that is now in place in the community as well. And we have all of our community midwives have new devices, both handheld devices and laptop devices, and have received training in the maternity medway system, which enables booking information to be collected at the time a woman books for birth, to be immediately available to all parts of the maternity service. We have some new digital equipment available at Queen's and at City, and we are in the process of rolling out more extensive training for staff in the use of that equipment. The next area of concern was around incidents, and particularly serious incidents where there was concern that we had failed to learn adequately from previous incidents, and we have completely redesigned our serious incident process for maternity. Again, Carol would be able to describe the details of the 3 times a week rapid review meeting that Carol chairs now to consider any incidents that may meet serious incident criteria, and for the review of those incidents and any immediate actions that need to be taken to in light of the events. We have some good examples in the recent weeks of incidents that have been described through that rapid review process, and where immediate action has been taken to try and ensure that such things don't recur. Finally, but most importantly of all the things I've been talking about, we have been working with the Maternity Voices Partnership to ensure that we hear the voices of women through this process. And we now have regular meetings with the MVP and have much better links with our maternity, with our mothers and their experiences. Chair, if I may conclude, I would suggest that we have had some progress since our last time in March. The CQC revisited us a few weeks ago and have removed the Section 29 improvement notice on the basis of the improvements they have seen. We had the quarterly review meeting with the Healthcare Safety Investigation Branch last week, who were very pleased to report to us that we had reported less incidents, and importantly, the incidents we had reported had less safety concerns than they had previously. But we are very mindful that there is much still to be done, and that this is not something that is going to be quick to fix. And we are particularly now looking at how we take what I would characterize as transactional actions in terms of buying equipment, training on basic equipment, and changing that into a much more transformational program, bringing together the safety improvement work and the culture work that we've been doing, such that we can create a culture that is safe for women, safe for babies, and safe for staff. There's many things we could talk about within this really extensive programme. I think it's probably best I stop and leave the questions to the councillors. That's okay, Chair.
Just before we move on, thank you very much for that update. Are Carol and Michelle speaking? Have you things to say? Are you here to answer questions? The reason I'm asking is, would you like to speak now, or would you like the questions being put to Dr. Girling first?
More than happy to take questions following on from what Keith's already presented, Chair.
Okay, how about Carol?
I'm happy to support questions. The only thing that I would add to what Keith said is recognising how immense bedding in a strong governance programme is within maternity, not just within NUH, but nationally. The organisation have also funded a Deputy Director of Midwifery, which is quite innovative for an organisation, and their remit is purely the governance and safety. So they don't get embroiled in the day-to-day operational, but they're more looking at the infrastructure that wraps itself around the service to maintain that safety.
All right, thank you very much. Can I ask then, members? Yes, Councillor Adams.
Thank you, Chair. Yeah, I'm interested in the. Thank you so much for what you said, by the way. Before I get right into it, the 51 CTG machines that was short. Working from an IT background, I'm very aware of when system replacement is required, the reporting process, how that comes about, how that's then logged, and how then those systems get replaced. What process is there in place for that? How did we get to a situation where CTG machines were short to that level? What process is now in place to ensure that when machines do fail, or I guess become old systems are replaced, how is that reported and by whom? And finally, is that part of are they replaced as part of a capital programme periodically as well, or is it purely in a revenue sense when these begin to fail that they are replaced? Thank you.
Thank you, Chair, if I may take that. We were not 51 CTG machines short. The vast majority of those machines were on a rolling replacement programme. Off the top of my head, I couldn't give you the exact numbers that were planned for last year, this financial year and the next financial year. I think that was about 37 replacement machines that we had planned. And we brought all of that forward to the first, it was within last year's capital programme. So these are capital replacements. Instead of buying just the 13 that were expected to be replaced last year, we bought the 37. We then did a survey of the unit and identified that there would be benefit to having additional machines, particularly in our antenatal ward areas. And we expanded that purchase from 37 to 51 so that we had additional machines available. We have a very comprehensive rolling replacement programme for all of our medical equipment, which is logged through our medical equipment service unit. And we have a medical devices committee chaired by one of our divisional directors who ensures that each year that those rolling replacement programmes are satisfied as the first part of our capital replacement programmes. Other things then come into the capital programme after that.
Thank you.
Ajanta, would you like to ask your question?
Thank you, Chair. Thank you, Keith. I've sat through numerous of these presentations, and first and foremost, I would like to say that huge progress has been made since the first NUH came to any Scrutiny meeting, which I attend both the city and county, so I get a double whammy of the presentation. So huge progress has been made, not least in the staff training and bringing up to the competency level of the staff, updating the equipment, liaison with the MVP. So I can feedback that you have built links from the first meeting with MVP. Now, my couple of questions are, can you tell us a little bit on the plan of staff retention? Because you're going to struggle, as we read in the media and everywhere else, that the staff are everywhere, all over NHS, and maternity services will be no different, are tired, exhausted, stressed, especially when any department gets an inadequate rating. That must put huge pressure on staff. So a plan on staff retention, that's my first question. The second slight concerning one, CQC has still again said that the plans of risk assessment and risk management are not always carried out. Now, is there any link between that and, the daily incident meetings that you guys are having? I've raised this before. The chain of information feed forward is there, are staff aware of the bottom-up feeding and the top-down feeding? How concrete is that? Or is there still gaps where information is leaking and lost? Because that's been one of the big issues with the bereaved parents, who have said right from the beginning, at least to Health Watch, that they would like each of those incidents to be used as learning and not any information to be lost. So those were my two questions. Thanks, Keith.
Thank you, Chair. May I defer to my learned friends on these two questions? Staff retention, Carol?
Thank you for those. So starting with the staff retention, I think it's fair to say that NUH is not isolated in terms of the challenges it faces with staff retention. Working within maternity services, like other areas of the NHS, is challenging and stressful for staff. I think some of the processes that we've started to put in place will hopefully go some way to helping that in terms of, and it links with the second part of your question, communication with staff is absolutely key. Involving them in the changes as we move forward. Nobody comes to work to do a bad job. They want to be part of the solution. Something that has struck me, I'm not a local person, but something that has struck me particularly around Nottingham is that the staff are part of the fabric of the building. They are part of NUH. They want to make their maternity services the best they can be. But to do that, it's beholden on people like myself and my team to make sure that we communicate with them. So we have been having what we call all about you sessions, where they have an open forum with myself and they can raise concerns, they can raise suggestions, and sometimes the best solutions come from the staff at the bedside, not from people like myself. So I think, for me, part of it is involving them in the changes, looking at their own development. I think sometimes it's easy to, whilst we've been talking about some of the training that's come about because of incidents, it's now about bedding in systems and processes, like you said yourself, so that these don't come as surprises, that we have a robust training programme to make sure people keep up to date. But equally, we look at opportunities where we can develop our staff, and we've started some of that by looking at our leaders in the clinical areas to make sure that they have the skill sets and the tools to be able to do their jobs robustly, and looking at other opportunities that they can learn from others to bring back to the service. We're also cognizant of the fact, like many other organisations, there is an exit of staff with experience, as some people in the same age category as some of us are starting to retire, and we don't want to lose that wealth of experience and knowledge out the door. So we're exploring a retire and return programme, so that it's about flexibility and not being too rigid and fixed. And sometimes, an organisation can get quite fixed and rigid in how it organises the staffing. And if you can be a little bit more flexible, then you are more likely to retain your staff. And that sends a very strong message then that we value the experience that our staff have. And then looking at innovative ways of recruiting as well. Staff don't want to see the same old going out for an advert, so they do want to see that you are becoming innovative and doing things that other organisations are doing. So I think it's not one thing; it's a whole package of processes, from communication, recruitment, and the training and development for the staff. So then learning from incidents almost flows from that. We've recently done a survey of our staff to say, are we getting it right for you in the learning from incidents and making those, getting those messages out. Now, we do send out communication, we do have meetings, and we meet with the individual staff, but we're still not quite there yet. And I think, we've got to find different ways. When you've got people who work shifts, not everybody lives on email, and I wouldn't want them to live on email. We've got to find different ways of communicating with our staff. So I'm working with the ward managers to make sure that we do that local feedback with their staff. But more importantly, those staff that are involved in incidents, and incidents do happen, and they will, there will always be incidents, hopefully less major incidents, but nonetheless there will be. It's about making sure that we have a timely meeting with the individuals or the individual involved, that they understand what happened, and that we identify, first and foremost, that we identify learning that is needed for that individual, and that they are supported, and that there is a consistent approach to that, and it's not a knee-jerk reaction. The rapid reviews that we do 3 times a week, we step them down if there isn't an incident, so we don't, most of the time we don't need all 3 of them, but it's good because we've now started to include the managers from the areas of the incident, so that they're more involved, and it's not just someone like myself with the doctors having that conversation. We bring more people to the table so that they can hear the debate and they can contribute to that debate, and then we can agree immediately what are the actions that we can do now to address it now, while sometimes there's longer term actions required. I don't Thank you.
Thank you. Councillor Martin.
Sorry,
I'm sorry.
Could I just add to?
Yes, of course.
It was only to say that from a new girl perspective, I'm in a fortunate position to be Nottingham born and bred, and I did my nurse training at Nottingham a few years ago. I won't say how many. So I'm very proud of that, and what I want to be able to do is to take all that Carol's talked about and make NUH the employer of choice, and that's the bit we've got to get to. So I'm hugely passionate about valuing staff's contribution, hugely passionate and careful that as an organisation we don't go top down, because when these things happen and you do get bad reports, as we acknowledge that we've had from the CQC, the tendency is to jump straight in as an executive team and a trust board and take control, and I think we've done a little bit of that. So I think there is much more that we can do with valuing the contribution of our midwives and all our staff, but in this case our midwives on the ground, because as Carol's pointed out, they're the ones that are delivering this on a daily basis. It won't be me that changes it. I'll support them and knock the barriers down so they can, but we have to get more engaged with staff on the ground to be able to, you know, to communicate with them, to give them the autonomy to make the local change. And I think if we do that, or that is our plan, that it is not I think when we do that, I think that will also have a positive impact on learning from incidents. So there's quite a lot that Carol's described in terms of detail, but our overall strategy really is to start from the staff on the ground upwards. Sorry, Chair.
No, please. Councillor Martin.
Thank you. Thank you, Chair. I'm glad you said that, because obviously the CQC have picked up on the staffing levels, and we know that nationally recruiting is difficult, and it is, but also the retention of your retiring staff is also equally as crucial. So the more flexible you can be with them, that's a really good move. I'm glad to see we've got a director of midwifery and a full-time maternity director, because that's really what I want to say is learning the lessons from what happened to Kings Mill 5 years ago when they had a poor CQC report. They took it head on, and they've turned it right round, as you know. And my real issue is, and I suppose that is the CQC's issue, is that because you're low on staff numbers already, and the training of those new staff and the existing staff is causing it's exacerbating the problems, because when you've not got the full book to work with, it's difficult. You're under pressure to start with. So I'm really glad you've just said what you said, because recruiting is crucial. It's a key element, because obviously you've got staff retiring and you've got new blood coming in, and they all need the experience of the elder staff. So how confident are you that you'll be able to reach the full quota of numbers?
I would challenge any organisation to say that they would be 100% recruited all of the time. I think we will always carry a small amount of vacancies, but I think if we carry on with the level of recruitment that we've got at the moment, and if we can retain some of our retire-in-turn midwives, because what I'm passionate about them is because a lot of the recruits, as you will know, will be qualified midwives. They need that steady pair of hands alongside them, so that they feel confident to go out and be that qualified midwife. I feel if we can bring those together, then the vacancies that Keith described just now feel are achievable.
And if I could just add to that as well, sorry, we have got a really good relationship with Sherwood Forest. We're really lucky to have that. So they've got an outstanding maternity service. You're right, over the last few years, they've completely turned their organisation around, and there's a lot that we can learn from them. Our relationship with the chief nurse there is excellent, and what we're agreeing at the moment, as Keith alluded to in his opening presentation, is rotational working between our midwives. So offering some of their really experienced midwives the opportunity to work in a much bigger tertiary centre and do a rotation round. And that's good for a variety of reasons. It's good for the midwives' development, but it's also good for NUH staff to see that there is world outside of NUH. Because often when you stay in an organisation for so long, you only see what's there, and being able to see the transformation that Sherwood Forest have done, I think will be excellent for some of our staff.
I'll just add to that, sorry. We also have budded with Coventry, and some of our more junior staff who are leading on specific pieces of work have budded with their equivalent at Coventry, who have already been doing it for some time, so that, again, it comes back to that learning from others to improve.
Yeah.
Yes.
Yeah, obviously you don't have to reinvent the wheel because it exists. And that's why I use Kingsmill as a reference, because the director and the maternity improvement director will show the staff that you clearly mean to have an action plan and support them in every way. And I hope that's reciprocal, and that flexibility will help you strengthen the team, because that's what you really need, because that's what it's a very rapidly changing area, and incidents can occur just like that, can't they? So that's the problem. So when you're understaffed, that's an issue. That's real. Thank you.
Thank you. Thank you very much. Councillor Gowland.
Thanks. Really great presentation, and particularly interested in the retire and rehire, because that sounds like an imaginative solution. Can I check? You talked about 16 down on the nursing staff, midwifery staff, I should say, and having recruiting 3+3 consultants. So what, in terms of FTE, will you be down on midwifery staff as a fraction of the full complement, and on obstetric staff at the end of this year, or at the end of in September?
I'll let others do the maths on the maternity, on the midwifery, if I may, while I just talk about the consultant piece. Yeah. The Ockenden report has a number of requirements within it that particularly relate to medical staffing. One of the key recommendations is around twice daily ward rounds, 7 days a week, which is something that we are not established to be able to deliver at the moment. So we have a morning ward round. We are able to fulfill a second ward round a second ward round on Mondays to Fridays at the moment, but we are not able to do that at the weekends without additional capacity. We also, as councillors will be very well aware, the quite appropriate world of women's choice is a very different place from where it has been before, and the explanation of opportunities and offers and consent for a way forward for women is now a much more fulsome process than it has been previously. And in order to allow for that, we have taken down the number of new appointments that consultants would see in outpatient clinics, for example, in booking clinics and other such clinics. And when you add in the whole of the requirements for consultant-led care through the working week, it does come to a total of 12 additional consultants over the current establishment. In reality, there is no chance of us being able to recruit 12 consultants to Nottingham when every other trust in the country is also looking to meet Ockenden requirements and increase its consultant establishment. And the reason we're doing this in a phased approach over 2 years is because we are confident that we will have people becoming available to us in that timescale that we can appoint, which is why we're putting out adverts consistent with people's availability. So we have 3 people that can currently apply, and there will be there's 2 trainees and somebody coming from outside later this year that would like a job with us. And we are very keen that despite that significant gap in consultant numbers, to not just appoint anybody that we can find, but to appoint people that will fit well into the Nottingham team and be good colleagues for the future. We're looking at 30-year appointments here. And so we are making sure that we're putting jobs out for people that we know will fit well into the NUH maternity service. And so that's 6 for this year. It will take us another year to get the second 6 posts in place, and only then we'll be able to meet all of the requirements. But that is consistent with pretty much every other unit in the country.
So can I just check, that's 12 posts down on how many in total?
A consultant post, I think we've got 24 or 25 at the moment.
Big look, John. Okay, thanks.
From a midwifery perspective, we have a whole-time equivalent of 325, and we've added 61 onto that, so that takes us up to the birth rate plus rate as is prescribed to us from Ockenden. So if our plans, as Keith described earlier, and the offers that we've made, if we take attrition, because we obviously get staff that leave all the time, and dropout rate from students, we should be, by October, we'll still have a vacancy rate of about 10%. But that's much lower than we've had previously. But to reach that, we've really got to look after the students that are coming. We've really got to take on board hugely, as Carol's described, the retire and return, and stop. So we know that we have 2.5 midwives a month that leave. We've got to try and reduce that, and that's better than it was last year, but we've got to keep bringing that down. So I would hope, and we're basing this on October because that's when the students all come out, that we would have a less than 10% vacancy rate for our midwives in October. But we've got a lot of, there's lots of caveats with that, and we've really got to work hard to keep our staff between now and then.
Thank you. Can I ask another question? On the training, can I just check, when staff have to be trained on the CTG and indeed for staff development beyond that, is it done in shifts? Is it done in their own time? And are they paid, and to what extent are they paid for development opportunities?
So it's paid time. We're not expecting people to do it in their own time. I think where we've got to move to is away from the ad hoc approach. It's fair that the ad hoc approach came in response to, the CQC, etc. Summaries. However, to make it sustainable, we're currently working with the team to go back to where you have a block of training and you are rostered on that block of training and you cover everything. It's not just obviously CTG, and the amount of training that you have to do now on a mandatory basis is growing all the time, particularly on the back of Ockenden. And it comes to around 7 whole days a year that an individual will have to do. And of that 7 days, there's a component that the doctors will need to join as well, so that we have truly multidisciplinary training.
Okay, thank you.
Thank you. Councillor Wilmot.
Well, thank you very much, Chair, and thanks for allowing me to speak on this issue. My first thought on this paper is that it isn't a good paper that we should be looking into at this present time in a good view, because to say that the Care Quality Commission people had to come in to the hospital and review the maternity services, and they were inadequate. It means that what measures do we ordinarily do on performance and success in the hospital itself, and obviously it must be inadequate at this moment. Otherwise, you would have picked up some of these things, and also the collection of data. The collection of data is very, very important, and some of these issues would have been picked up if you'd got the correct things in place. Can I say also that checking on the competency check, I'm doing a competency check of the staff at this moment. Surely that should have been done when they were first employed. If it wasn't, then it should be put into the questions when you ask the people when they come for these jobs, because we need to make sure that we've got the very best staff. And if, of course, they're not up to date with a lot of the situations, that they should be put straight into an area where they can learn all these things, I would have thought. Also, it says that you're now looking up front, asking frontline staff about seeking improvements. I would have thought you'd have done that always, because the people that are on the front line are the people that know exactly what's happening, and to make sure that you do continue with this frontline staff. You should have a committee formed that with this frontline staff as part of that committee, so that you get to know exactly what is happening on the front line. And I'm glad that you have brought these extra staff in, because that'll be their job. There's no doubt about it. Thank you.
Would you like to comment on that, Dr. Gowling?
Thank you, Chair.
Many of the points you make are well made, Councillor. We have been aware that we have had difficulties within the maternity service for some considerable period of time. We did take some assurance last year from 2 national data sets, which showed that we had a significantly better than average that our stillbirth rate and neonatal death rate was significantly better than the average for the country. And we did take some assurance from our patient surveys and women's surveys, which showed that we were significantly improved in the experience of women through the unit. We absolutely recognise that we didn't take enough attention to some of the information that was indicating that those problems were not resolved, and we should have taken action earlier. And we have apologised publicly for that, and I would apologise for that again. We have taken significant action in this last period, as I hope councillors can see, and I believe we are starting to make some traction for the first time in some time on these matters.
Thank you. Councillor Welsh.
I came on first time. Yeah, my name's Michelle Welsh. I'm councillor for Arnold South, and as I said, I had a baby within your services 14 months ago. This is quite hard for me to speak about. I haven't spoke about this in public, and you can already hear that my voice is starting to wobble a little. My pre-actual having my baby, I had consultant Dr. Deering, who had a number of medical problems, myself and my baby did. And I had consultant Dr. Deering, who was out of this world fantastic. And I do believe that she is responsible for getting me to the point where my baby was ready to be born. So I'd like to place that on record to start off with, that was wonderful. My actual experiences of the department at Nottingham City Hospital and what happened to me and my baby was nothing short of horrendous. Sorry. And I'd like to place that on record. So I have a number of questions without talking too much about the level of care that I received and the level of care that my baby received. I believe that when we talk quite flippantly about the Ctg machine, the Ctg machine was letting me and my baby die, letting me and my baby down to the point where my baby was put at very serious risk. It was a very old machine, and the midwife said she was finding trouble to find my baby's heartbeat, and actually have to call the consultant back in. It was very dismissive towards me and the midwife, unfortunately. Prior to that, I'm not going into all of the details, and I apologise if, prior to that, I was told by my consultant, Dr. Deering, that the moment that I felt any contractions, I was to phone the midwives at Nottingham City Hospital and let them know, and they were to bring me in straight away. But the reason I had to phone them is because they didn't always have space in the City Hospital, and sometimes they had to Queen's. I was dismissed by the midwife over the phone, who didn't look at my file, to tell me that it was probably Braxton Hicks. It was my first child, and I didn't really, because it was my first child, I didn't really know what was what. My waters broke, and I ended up having to have an emergency C-section. I was planned for a C-section about 5 days later, but it was this emergency C-section where my waters broke that put myself and my baby in quite a bit of danger, to be honest. I will say it was the beginning of the pandemic that I had my baby, so there was perhaps some staff shortages around that, but there was definitely staff shortages, and I was told to rest after having my emergency C-section, and I was reassured that my baby would be looked after and seen to. When I woke up, my baby was covered in sick, it was dry. I actually have a photo of it, not because I took a picture of my baby covered in sick, but because I'd woke up a bit in a daze and I thought, there's my little baby boy. It wasn't until I looked afterwards that I saw what state he was in. His hat had fallen off as well, and it turned out his nappy was soiled and very, very, very wet. I'd been asleep for an hour and a half. I was informed that we were very short-staffed. I said that my baby felt cold to touch, and that was a problem. His temperature was taken, and then there was a mad rush to try and warm the baby up. There were things that happened after that and before that, and as I've said, it's very, very hard for me to talk about. And subsequently, the services afterwards were very much disrupted, the postnatal services, because of the pandemic. And as I said, it was a pandemic, so there is part of me that does understand that actually as a department you didn't have any PPE, for example. As a department, you know, I'd already been told my partner could only be there for 20 minutes afterwards. I understand and take all of that into account, and I'm so grateful for what the NHS does. So the point that I'm trying to make is I'm not necessarily trying to make a big issue of the experiences necessarily that I went through. But in all that I've heard today, I set up a group for lockdown mums in Nottinghamshire that started off with 10 people postnatal. It's now got 170 members. Some of them do cross the border into Derby. I asked them yesterday via our internet what their experience is. And one of the things that they said, the predominant thing they said was that they didn't felt listened to when they were on the wards. So when they were saying something was wrong, they felt that that was being dismissed as, oh, that's a normal pain of pregnancy, or when you're phoning up before. And that caused for them unnecessary worry. So that's the first thing. The other thing is as well, I do believe you put a consultation up for service users at one point, but it was on for a very limited amount of time. You spoke a lot today about the training of midwives, the Ctg machines, etc. But what are the service users saying? Because as far as I'm concerned, out of those 170 women, a lot of them have got a story to tell, and it's not all bad actually. Some of them, you know, despite the pandemic and everything was going on, had an absolute wonderful experience of you know, the service that they had. I wasn't one of those, unfortunately, but others did. And I think there is something out there about capturing what they're saying about the service, and also how different it was because of the pandemic. I think that needs to be captured as well, because I've walked away from maternity, you know, from your maternity leave feeling quite upset about what happened, as you can imagine. But it would be good to know, was some of that an impact? You know, was there not enough staff there because you were having to send them, you know, people home? Why was that? There's a lot of questions. So the first plea really is about the listening aspect to people, and perhaps setting up mechanisms for women to feel empowered to ask those questions and also get, you know, the reassurances and the answers that I need. Again, I understand that midwives can't always stand there and consultants and give you a full, because they're so busy. I do get that, but that was the thing that came up. The other thing is what Mike said about the level with regards to the Ctg machines. I think I'm saying that properly. It should have never have got to that level. It should have never got to the level where I'm in a maternity suite and the machine is not working properly to measure my baby's heartbeat. That should never, ever have happened in this day and age in this country. And I feel quite adamant about that. And then the other thing is, it's basically a question to yourselves with regards to, you know, groups of women. I'd quite happily put some women your way that would be gladly tell you their story of their experiences of maternity services, because I'm sure the CQC would like to hear those positive ones. And perhaps there's, you know, this is where we were and this is where we are now with regards to experiences. And I do have one other question with regards to staff capacity. There's been a lot of talk in the media recently with regards to the EU settlement scheme and how that's impacting perhaps on NHS staff and their ability to stay, and visa hikes and stuff like that. Is that having an impact on midwifery and your ability to have the amount of staff that you need? And that's the question. And I'm really sorry that I wrote this down. I'll be one second. And then the other thing is regards to capacity issues. So we had a number of women that were saying that they were going to have an induction, but they have to wait for a phone call that day to see whether they're going to be induced that day. And they could get a phone call and they might not get a phone call. So they're sat there with their bags packed. I was quite shocked by this, you know, that I had friends of mine that are sat on the seat, you know, husband's had a day off, bag is packed, but they don't know whether they're going to get that call as to whether they're going to go into hospital that day or not. So yeah, it is another question with regards to capacity, you know, the amount of people that are having babies and if that's still, you know, an issue.
Dr. Girling.
Thank you, Chair. And I'm sure I know I speak on behalf of all three of us to say we're desperately sorry for your experience. And that is not our ambition for the maternity service at NUH. And I know that you're not alone in that experience. We have heard that story from other women too. And I can absolutely say that we have 100% commitment to turn that round, to make that a better experience for women, and better outcomes for babies, and actually better for our staff too, because our staff also are finding this period very, very challenging. But I'm very sorry. There are many aspects to the things that you describe there. We'd be very happy to meet with you individually outside of this forum to talk about your personal experience and your personal care, rather than necessarily going into that detail here. We would welcome the opportunity to meet with some of the women in the lockdown mums group in order to hear their experiences, both good and bad, and as I said earlier, and as Ajanta indicated, we have strengthened our relationship with the Maternity Voices Partnership, but this is all about women. This is all about women and all about babies, and making this service right for women, and so it's always invaluable to us to hear that. In terms of I'll deal briefly with the EU settlement, and then I'll pass to colleagues around the capacity for the induction of labour, if I may. The EU settlement is not an issue in relation to maternity services in the same way as it is for other services across the Trust, because we have very small numbers, if any, overseas midwives at the moment. We are looking at an overseas midwife recruitment programme, but as you may well be aware, other countries have very different setups for maternity services, and it's not easy to translate maternity practitioners from one country to another. And so, I don't think that's a significant issue. Carol will be able to describe more.
So again, truly sorry for the experience that yourself and other women have experienced, but the only way we can move forward is to work together. You're absolutely right. As Keith said, we've been working with the Maternity Voices Partnership, but also more locally, we have women in our services every day. And so we've been developing our staff to work with the women on the ward to actually improve the experience. Example I would give is one of our more newly appointed managers has been working and listening to what the women have said about their pathway we have for elective caesarean section, for example, which women didn't like, and the way our service was organised, it made it worse. So she's listened to them and she's put a proposal forward, which everybody is on board with, the doctors and the midwives, and so she's in the process of making that change. And I think a lot of the changes to make things better for the women come at that level. And so that's why we've sort of turned the tables a little bit to get our staff working with the women to listen to their stories. We've got a couple of our midwives who've been doing birth debriefs, and we've had some really powerful stories, and they are now being put into the education programme, like you said, because there's nothing more powerful than listening to it from the woman's perspective as opposed to a theoretical story that we would put in place. In terms of capacity for the hospital, we do still struggle some days when we have activity levels that are high, but sometimes it's not necessarily just about the numbers. It's also about how unwell a mum might be, and how much attention that mum needs from a midwifery and an obstetric point of view, which then draws on the staff. So you can have an ideally staffed unit, but still not have the capacity, and capacity means not just the beds and the staff, it's the acuity of the women before you. And that's why we have this daily meeting, that we bring both sites together, and that's the beauty of the virtual world now. At least we can do that in a more timely fashion. And we have the obstetricians, we have the midwives, the anaesthetists and the neonatal staff, and we come together once a day to actually look at what our staffing is, what is our acuity, what do we need to do to manage that flow. Now, sadly, that does mean sometimes that we have to divert the service from one site to another, and sometimes we do have to, because of staffing levels, we do find ourselves sometimes struggling to support home births. All that said, this week I've got one of the community midwives coming to me with a proposal for how we can secure the home births. Inductions of labour are often the area that suffers the most in terms of delay, but we don't do that lightly, and all of those women do have a senior medical review to make sure that that is safe to delay that induction. It's not ideal, but specifically how you describe that, and we are working as one of the programmes of work to improve that pathway for induction of labour, but you can't just take one component. It's about how do we bring it all together.
Thank you. Before I just ask anybody else for questions, and I've got Councillor Gowland coming next, I just want to ask a few things myself. Basically, what I have heard from Councillor Welsh and what I've read in this report does give me some cause for concern, because we've had somebody speak from the heart that, granted, it happened 14 months ago, but it's something she's got to live with. I have concern, as Councillor Adams referred to, that the heart monitor machines were in such short supply that you've had to order all these new ones and train the people using them, which takes time to train. We have an issue of 35 midwives, I think you said, and 58 to come by October. My quick maths makes that about 93 midwives. How trained are they? Are they coming in fairly inexperienced, or are they coming in very experienced? I mean, you have mentioned how you want to keep your staff that are retiring, and that obviously is a very good idea, but you've got an amount here of 93 midwives coming in. Are they trained? What I find in this report, it's not detailed enough for me. I don't know what the other people feel. It says there are 93 midwives. It doesn't say whether they're coming straight out of nursing training, whether they've been experienced, whether they've got to be trained up. If they've got to be trained up, that takes time. Also, my question is, I mean, how do you judge safety? How do you ensure ladies coming into the maternity unit at the moment are safe? Because you've referred to incidents, which concerns me, because I would like to see what an incident is. I mean, just to say you have incidents, what does it mean? I mean, what does it mean? It is not in this report. And it needs to be. We need to know how many fairly simple incidents have you had, which are not long-standing with the mother and the baby. How many incidents have you had that you've been able to retrieve and keep the baby safe? But how many incidents have you actually had where there is suffering for those babies for the long term? Because just to say there's incidents is not sufficient for me. I don't know what other people think. I mean, are you able to respond to the service pressures? What happens if 6 midwives ring up and say, we're ill? I mean, we've had COVID to deal with, and I have to at this point say that, everybody has worked under extreme difficulty, and that I think the whole committee would agree with. But if I had a relation of mine coming into Queen's at the moment, reading this report, I would be very concerned, because it does not give me the idea that you've improved very much. You've got the fetal heart monitoring equipment, but people have to be trained. You've got new midwives coming in, a total of 93. Do they have to be trained, or are they coming in really top-notch, fully qualified, fully knowing what they're doing? And also, you did say at the March the 9th meeting that by the end of this year, you will be close to achieving a good status. Are you on track for that or not? And when you say you've got staff ill, what is the morale of the staff? That to me is very important. Obviously, you've got sickness, and I dare say some of them have probably got COVID, which is most unfortunate if they have. But what is the morale of the staff? Because we all know that staff recruitment is difficult, and you've got to somehow keep the staff and retain them. But you've already got the new ones coming in, and I would like to know, back with a report, because you can't do it today off your head, I would like a report back to say what stage of training those midwives are at, what experience they have, and are they coming in with somebody having to watch over them, or are they coming in with full expertise and nobody needs to watch what they're doing? And I would also like to know what these incidents are, because it's just not sufficient for me to know that there's incidents. We don't even know how many. Are there 6? Are there 66? I mean, we've absolutely no idea. To me, I would like to see a much fuller, detailed report. I would like to see what has happened. I'm happy for you to redact the names so that we're not interested who it is. But as a committee, I feel wholly responsible that we need much, much more detail.
Sorry, could you do you want to start?
Chair, I apologise for the report if it's not detailed enough for you. We have all of the information that you have described, and I'm very happy to provide that in a supplementary report to the committee.
Thank you. Well, perhaps, I mean, we'll see what happens. Other people are surely going to come up with some questions, but perhaps I've got 2 suggestions to you, actually, and one is that you possibly come back to the October meeting and bring all this information so that we can drill down, which is what we must do, because we've got ladies out there going into Queen's. We've had an experience from one lady here today. We must know that people coming into Queen's to deliver a baby, which they might have had great difficulty in conceiving in the first place, and it's extremely precious to them. And I want to know they're going to be safe. Another thing to point out is the aftercare. They have their baby. This was more from experience, not from me, but they had the baby, and it was very, very good in the actual birthing unit. But then they weren't allowed out that day. They were told to stay overnight, but weren't seen for the rest of the time. They might as well have been at home. They were shipped off to another ward, and there they were left. Difficult to get a jacket potato to eat, I mean, that's not aftercare, and it's not mentioned in here at all. What kind of aftercare do these ladies get when they've been through all the stress of childbirth, needing some help, probably not having people with them? And a baby is very, very precious, whatever, as you know, because you're in the field of delivering them. But would you not agree that you're giving, to me, still a lot of complacency? It's not detailed enough. I would like to see it much more detailed, because we are here to make sure that our ladies are going to be safe.
So, Chair, very happy to come back to the October meeting, of course. Very happy to give a supplementary report after this meeting, as you wish.
Thank you. Thank you. So really what I'm wanting to know is the number of 93 midwives, how trained up are they? Are they obviously they're trained, but how experienced are they? Because 93 new people into a hospital, albeit on shifts, is a headache for somebody trying to look over them, unless you've got a lot of experienced staff. So do you put an experienced staff with a less experienced member of staff so they can help the less experienced staff? And then with regard to the fetal heart rate monitors, I mean, how are you getting on doing that? How many people are trained? How many more have you got to train? Are people sitting next to those monitors with people who are trained, who are learning how to use them? I mean, a lot of this concerns me, that the staff that you have got that are actually trained are probably spending an awful lot of time trying to teach those that aren't. And that worries me, because it means that they've been taken off from somewhere else. So it's those things I'm looking at: the incidents, the staff, how well qualified they are, and whether they're all having to help each other because they're not qualified. That is terribly important. And the aftercare. You know, what aftercare have you got, and how are you getting on with the fetal heart rates? But that's me for the moment.
Chair, would you like us to pick up some of those points?
Please,
initially?
please.
Could I just start with, I'm sorry that you think that we're complacent, because honestly we aren't. So the report obviously doesn't give you the information that you require, and I can clearly see.
I don't think it gives the feeling that I would feel safe.
I understand that entirely.
I don't know whether anybody else feels that, but Councillor Wilmot did allude to it.
So certainly we have a long way to go to assure ourselves in the organisation and assure you and the women out there that we have the service that people would feel safe to come to, and we appreciate that. We're working absolutely as fast as we can with that. With regard to the incidents, just so for your awareness, and we will bring we're happy to bring a detailed review of the incidents. They are reported in our public trust board, so as required to do through Ockenden. So on our public trust board there are the maternity incidents. So we do report all our serious incidents that happen in the organisation, because of course we have incidents across the whole of the organisation, not just in maternity. And then there is some detail around the maternity ones in public trust board. So but we will break that down and bring that back to you in October. With regard to the midwives training, I'm not a midwife, I'm a nurse. Carol's a midwife, but we always put less experienced staff with experienced staff. So please be assured there is some of that. And for this particular circumstance with the training, we have got external supporting, because you're absolutely correct. If we'd have taken our experienced staff away to put with inexperienced staff, then we would have left it an even worse position. So we have outsourced some of the training to be able to get additional staff in. And we've also had some of our nursing colleagues that have moved over from the nursing side to maternity to support the midwives in the training as well. So we have put extra in on top of that. The other bits that you're alluding to, Chair, I think the best thing that we can do is to give you more detail and to have a much deeper dive discussion with you, so that we can give you further assurance.
Thank you. Councillor Gowland was next.
Thank you. When I read this document, I didn't actually find it complacent. I found it defensive. And I think the examples that have just been given of the data that's missing is the data that I had to ask for. It would be really good to see a table that really shows the staffing as a fraction and the turnover as a fraction, because that's what matters. So I think, and I'm sure you agree, that it's terrifying that you're down by a third on your obstetric consultants count. And I totally, honestly, I do get the problem of it being a 30-year appointment, and I do get the problem of having to fit expertise within the department, and I do get the problem of the Royal College's training programmes. But this strikes me as an emergency, right? You know, being down by that fraction, I don't see how you can do it. You know, it seems to me, and it's not like gastroenterology. You can put the surgeries off. These babies are coming through the door, and this is your problem, isn't it? You can't manage the demand. So I think, you know, is there nothing you can do that's outside the box to try and solve this problem in the short term? Because I can't see how you can do the job with a third of the staff down.
Chair, thank you. So the we are consultants down. There's no doubt about that. The third allows for a significant upgrade, if you like, to all the care that's currently being provided across the board. So it's not that we're not doing the job. We're not doing the job in terms of the way Ockenden would expect with the 7-day-a-week, twice daily ward rounds. We're currently not able to reduce the clinic slots to the numbers that we would aspire to get to with the additional consultants, so that there's much more time for women in that clinic appointment. We're not able to assure that we can deliver inductions of labour on an absolute required basis every day, so that some women have the experience that you heard about earlier. So we recognise that those are things that all of which we can't do because we have got those gaps. The consultant body at the moment is working well above and beyond their standard jobs, which would effectively cover probably 3 to 4 of those additional jobs, plus the 6 that we're putting in this year. By the end of this year, once the 6 are appointed, we will still be short, but the gap will be a fraction of what it has been. And we have been able to have a small number of locum consultants in this period to help us, but every trust in the country is appointing obstetric consultant jobs at the moment, and nobody will take a locum job when there's a substantive job readily available to them. And so yes, there are things that we can do out of the box, but everybody's doing them. And the Ockenden requirements mean that every trust in the country is down by a number of consultants, in the same way that we were down by a number of midwives when we looked at the safer birthing numbers. And so at the moment, the consultants are working, as I say, significantly over and above their 40 hours a week job planned to support the service and make sure that there is adequate cover.
Can I just ask one more question? What's the interaction between obstetrics and gynecology clinically?
A proportion of our consultants do a mixture of gynecology and obstetrics, and a proportion do purely obstetrics and a proportion do purely gynecology. Going forward with the jobs, in order to attract the best people that we can get into those jobs, we are working with those people to make sure we have the right balance of the jobs available. We have sessions available in gynecology, and one of the reasons that we have the gaps in our obstetric service is because in the last year or so we have been supporting a gynae development because of the number of women waiting for gynae surgery. So we have effectively robbed Peter to pay Paul, but the amount of consultant time engaged in gynecological work has significantly increased over the last 18 months, some of which has come out of the obstetric service.
All right. Councillor Adams, please.
Thank you, Chairman. Yeah, I just wanted to come back on a couple of bits because I realised that, having listened to Councillor Welsh, that I hadn't really drilled down enough on my point around the Ctg machines. I just wanted to touch on the point that the process that is in place to ensure that the machines that fail are reported and how that comes about. Who do they report it to, and how is that prioritised in terms of is there a priority 1 if it's completely failed? Is there priority 3 if it's got a slight issue? Is it or do we just ship it out straight away if there's any sort of fault with it? So yes, if we could just drill down a bit more on that, that'd be fantastic. Thank you.
Carol, do you want to talk about the MESU process, or to?
That's okay. So that's part of the overall improvement work we've been doing, and even before I came here this morning, I was actually out on the ward walking around strangely enough, looking at equipment and talking to the staff around, you know, their processes. And I think it is fair to say that given all of what was going on in maternity, some things from the shop floor got pushed to the side wrongly. But, you know, in fairness, when they're trying to also care for women, I can see how it's happened. However, you know, we are now with the matrons, with the ward managers, because the conversations that I've been having and the expectations I've set with the ward managers is around that responsibility and accountability. So it starts with the clinical team identifying the issue. It then is making sure that they engage with the services, be it the medical equipment, it may be the digital services, depends on what the issue is. And then working with Michelle and Keith to ensure that there is that partnership and responsiveness from those departments. So I think we are strengthening that across the organisation to make, because it comes back to your point about, is this a priority 1, 2 or 3, rather than, oh, it's a piece of kit that's waiting. And so we're going line by line at the moment, making sure there's no other gremlins sitting there waiting, because the processes are in place, but I just want to make sure that we are using them appropriately and that staff are aware of what they are, because we've got some newly appointed ward managers and I need to give them the tools to do those roles properly, because it starts with them.
And just to add to that, as an organisation, clearly we have a medical devices department, we have a clinical engineering, we have a department that focuses on making sure that our equipment is checked regularly, does have its routine updates. On this occasion, there was a queue getting into that department. Part of that would be because of COVID, so lots of things had to be slowed down because of social distancing and because of all the other rules and things that we've had in place. But Carol's right. What I did last week and what we're doing now is looking at the absolute list of pieces of equipment across the organisation, not just in maternity, that are waiting. But we do have a policy, we do have a process, we do have a formal update of equipment. I think the bit that we've got to get better at is making sure there isn't a queue of equipment, and the ward managers on this particular occasion didn't escalate to us that they were waiting for these bits of equipment to be fixed. So I think that's the escalation point of saying, actually, we've been waiting for this to be fixed for 2 weeks or whatever it is something that we really do need to get better at, because that's the bit that we've not picked up on.
And just on that as well, if I may, Chair, is just to say that to ensure that the departments that are taking this equipment into their job queues are then feeding back at the point to the staff on the floor as well, because, you know, there's nothing worse than, well, I'm going through it at the moment here. My laptop's got an issue with the camera. It's gone away. It's hopefully going away this morning. You know, you need to know when that's going to be back into operation again, because you need to know you can do your job role with confidence and deliver that for the people.
I absolutely agree. The feedback loop is key to this, and we've got to improve that, and that's something that we've picked up on the back of this.
Oh, just one more thing, if I may, Chair, sorry. Would it be possible to see that process in the report that you're returning back to us, please, the documented IT process of how we go about ensuring that in its, you know, documented form, if that'd be okay, the life cycle as such. Thank you.
Thank you. Councillor Wilmot.
Thank you very much for allowing me to come back. Just reading this report, I'm just looking at the progress with Ctg training. It said here that it was 36% of the midwives. Just want to make sure I'm right on this. Is it 36% of the midwives were trained up initially with the Ctg machines, and now 67% are competent in using them, and that 75% of the doctors are in training? Did that mean none of the doctors could use the Ctg machines before? It says 75% are in training. It doesn't say that anybody had any competency in using that situation. And 90% of consultants, did that mean 90% of consultants are in training? And again, none of them knew how to use the equipment. And it says that completion expected in May. Does that mean everyone is now competent in using the Ctg machines? Also, you mentioned that IT usage within the department was not 100%, and that you were concerned that some of the information may not be getting out as quickly as it possibly can be. I just wondered if there was possible training for these midwives, or is it the fact that they don't want to get involved with IT system? But I'm afraid in today's life, you've got to be able to do a proficient amount of IT to be able to do the job correctly. I would have said that, and you know, that must be put forward as a proposal to them that they must, if they want to keep in that job, because you're on the job and very often you get a message through on your IT machine, whatever it is, and to give you some more important information. Whereas the days of people running around the hospitals with a piece of paper in their hand, I hope it has disappeared now. So, you know, I'm just really concerned about it. And then finally, I think we ought to have a report on things that happened in this midwifery department. How many people were treated last year? How many were treated this year? Can we have the serious incidents? How many there were? And the majority of them, were the ladies or the women happy that it was resolved? That problem was resolved. We would like to know a little bit more information and all the possible information on some of the other issues as well. Thank you.
Dr. Girling. Dr. Girling, could you put your microphone on?
Pardon,
no worries.
Doctors in training are doctors who are fully trained, have completed their medical training, but are on a training programme, but not yet on the specialist register, which allows them to be appointed to be a consultant. So all doctors go through a period of training beyond their medical school training before they become consultants. Most of us for around 8 to 10 years of training after a medical school before we're appointed to be consultants. Those are doctors in training. They are fully trained in the day-to-day work that they are expected to undertake at the level they're at in the organisation, but they then progress through levels of what previously has been known as senior house officers to registrars to senior registrars, is now termed by years of progress. But those are the doctors that are in training. The training that is referred to in the document is the Ctg competency that they've undertaken and that they have completed. And they will be trained as part of their training, and then they have to undertake an annual competency assessment. At the time that was written, 70% of people had completed that, or whatever the number is in the report. The report was written 4 weeks ago, and today that's 94%, with the remaining doctor that needs to be trained on maternity leave. The consultants are 100% have completed. 100% of consultants have completed the competency assessment in CTGs, and the midwife numbers are currently at 86% as of today. The report is not today's report. It was written in advance of this meeting, and we are continuing with this training programme on a day-by-day basis.
May I come in, Chair?
Yes.
The position, as you said, completion is expected in May, so it hasn't been complete. That's all I wanted to ask you.
So we are 16 midwives short at this time compared to where we expect it to be at the end of May.
Can I just add to that?
Yes, please.
I would just like to qualify a couple of points. So within any maternity department, you have a set of mandatory training programmes that you have to do. One of them is the CTG. Now, no matter how experienced a doctor or a midwife is, they have to go through their annual updates for that specific training. For CTGs, to make sure that they maintain competency and to keep abreast of current practice. So the actual training that Dr. Girling referred to at the beginning, people had actually completed that. The competency is to assess. It's another layer that is additional that we have at NUH just to give that assurance, and it's that has taken us a little bit longer to do. So the training was complete, but the competency assessment of it, again, people have to do it. It doesn't mean that they don't know what they're doing. They have to go through that. And then the machines are a separate piece of training altogether. Every time you introduce a new piece of equipment within any department, within maternity, outside maternity, you know, technology moves on, as we know. And so we have to make sure that everybody's trained how to use that piece of equipment before we put it into main play. And that's the training that we're doing on the equipment. It's not that people don't know what they're doing, it's the fact that it's new equipment that we have to train on. I just wanted to, and yeah, I totally agree with you. It's an IT world and we do have to use technology. Part of the problem has been that there was, you know, some of the handheld devices to make it easy for people to do it in a timely fashion. We've had to increase the number of those, but it's part and parcel of our day-to-day practice now. And some of our medical records weren't digitalised. That's where we're moving to the 100% digitalisation now.
And just to add to that, Chair, that about the IT, this is an organisational issue. It's not an individual midwife or doctor issue. They do embrace IT. They have to. We all have to embrace IT. But the organisation didn't have enough pieces of equipment, didn't have the same IT system in the hospital as it did in the community, and that's the IT issues we've been sorting out.
Thank you. Councillor Bailey.
Thank you very much, Chairman. So I'm following on a little bit on the IT issues. So I'm reading the summary of progress, and this is on the safe practice section, where it mentions additional new IT equipment distributed in all areas. Digital midwives due to commence in May. I just wanted to ask, you know, did that go ahead? Because I've looked at the CQC report that mentions there continues to be issues with connectivity, both on hospital sites and in the community, and a need for more IT equipment. So I'm just wondering if you're following through on that one. Thank you.
Shall I pick up the connectivity bits and then, so in brief, and Carol will happily give more information around the digital midwife. We have one of our midwives is in the role as a digital midwife part-time, started in May. We have a full-time digital midwife that is starting next month that will supplement that. And we have found previously, when we have had significant concerns around IT, that to have nurses specifically focusing on digital issues has really supported clinical teams to make the most of that equipment. It's a very well tried method through the organisation, and we've already seen real progress since our first digital midwife has been in place. In terms of the connectivity issues, NUH not only looks after the services in the acute hospitals at Queen's and at City, it also looks after the community service. Historically, the community midwives have linked much more closely with the primary care team, the GPs, and used a GP IT system rather than the Trust's IT system. And the GP IT system and the Trust systems do not talk to each other, and that's an issue nationally. We have moved the community midwives so that they work primarily on the same system that the acute trust works on, because that's the flow for the woman. The woman experiences the maternity care through the community midwife and then into the trust, rather than typically to the GP. The GP service is also updated, but in a different way to how it was done previously. And so in order for that record to be updated in the community on the trust laptops, that needs to be in a Wi-Fi area. We have got trust Wi-Fi throughout nearly all community settings, but there are a couple of community settings where that is proving very challenging to work with the community Wi-Fi provider to install our equipment alongside the current equipment. And so there are a couple of areas where we still have got further work to do, but the vast majority of the issues in the community with connectivity have been completely resolved. And as I say, new equipment has been issued to all of the staff. Carol, do you want to pick up any?
So in addition to that, we would also understand that, you know, introducing digital systems and new electronic patient records is challenging for people who've been used to another way of working for some time. We've complemented the role of the digital midwives by also seconding a very senior midwife whose background is digital and has done this elsewhere. So she's working alongside them. We've established actually a digital programme improvement board. So that brings the clinical service and the digital services together rather than it being like this. And we're working more hand in hand. So there's one plan as opposed to two. And also we've been able to gain the support from external regional and national digital leads so that we can learn how things have been done in a better way elsewhere, so that we share that learning and bring it internally as well.
Thank you, Carol. Councillor McGrath.
Thank you, Chair. First of all, I'd like to thank you for everything you've done, the NHS and all that, all the way through and for years. But my question's quite simple: is do we have a plan about recruitment and training? Because throughout this, what we're hearing, I'm unlike Councillor Willamott, I'm more horses for courses. And I'm sure as you get, there's trauma nurses, there's different nurses in there. I mean, obviously, between the people you are, very respected people, there must be a training schedule. And when you're going into a situation, especially in maternity and the things that you've gone through, and you've been short-staffed, surely we must have a goal at the end of it that I'll bring up my daughter now anyway. I think she's training for 5.5 years or 6. I can't remember off the top of my head. Obviously, she's on the wards. Going back to my horses for courses things, she might be good at IT, but the other things about the care and the use of the machines, do we actually have a signing off programme as well? Do you understand what I mean? And that must run all the way through. And on recruitment, especially, I mean, my daughter was, I suppose, picked up because a mate went into it, or a friend went into it. How do we recruit the right people? And do we go out to schools and colleges and all that, which then gives them the opportunity to get in earlier and train them earlier? Because obviously it's been a baptism of fire for a number of young students. As the lady said over there, you won't know your turnover again until they've gone through. And with more people going off sick, which is highly likely because of a lot of people are going through, you then might be back to square one. So have we got a good recruitment programme where we're reaching out to people and saying what they might expect? Thank you.
So you're absolutely right. So yes, we've started the recruitment. We've got a good recruitment programme. It comes back to the point that you made earlier, Chair. Nationally, and it's no different locally for NUH, a lot of those recruits are newly qualified midwives, but they are trained with a majority of our students that we recruit are trained within NUH as well. So we know our students, and there is quite a robust competency framework that they have to meet certain things before they can be passed and before they are deemed as a qualified midwife. Even then, at NUH or any maternity unit that you would go to, as a newly qualified midwife, when you come into an organisation, there is something what we call a Preceptorship Programme, which takes you through a year or 2 years, because if some people are part-time, it may take them a little bit longer. Again, that's part of a rotation, so they rotate through all of the different areas within the maternity services as a qualified midwife, and there are specific goals that they have to meet as part of that, and that's a normal process of preceptorship. And we have more experienced midwives who support them in that process. In addition to that, what we're wanting to improve is for our more experienced midwives who come in from outside, is to make sure that there is a robust orientation and induction program, so that I may be an experienced midwife, I know how to look after a woman, but I also need to make sure that I know where everything is in quite detail within NUH. And so does that answer your question? There was something else you asked and I've forgotten.
Recruitment element, wasn't it?
So the recruitment, we've actually, from the Trust's perspective, we've actually got quite a large workforce programme which is supported by our HR department as well as our clinical teams. And part of that, it comes back to what Keith was saying, because we want to retain people, it's about the culture, because those sort of things get out into the network, don't they? And so, you know, we need to be able to attract, and we're looking at things around, you know, how can, if I'm a midwife at NUH, how can I attract my friend, like you've just described with your daughter? So there is there's multiple elements to our recruitment programme in terms of how we're trying to recruit, not just about the students, although we have increased the number of student places as well, which is, you know, we've got to keep the supply coming. So we've got, obviously we work with Nottingham University, but we've also just signed up with Derby University, so which is actually quite good because you get a mix of students and not all just one source.
Everything that Carol said goes for nursing as well. So, you know, we have a really big recruitment programme for nursing that includes about 30 overseas nurses coming to NUH every month. Obviously, that's been difficult for us because lots of them are from India. So over the past few months, that's really been slowed down you know, because of the pandemic. But we do have a really good both training and educational package for them and recruitment.
Thank you. Councillor Garland.
Sorry to come back, one more question. The thing we haven't talked about is the handover process, and that's been highlighted in your response as well. Could you just clarify, is the handover joint between the nurses and the medical staff? I think that's what you're saying in here. And is it at all levels of staff from senior within a ward team? Thank you. Just one final thing. We have as councillors, or at least as a borough council, we get information from the fire service and the police service that we can share with our community. And just think in terms of recruitment, I just realised we get nothing from the NHS, you know, for good news stories and stuff that we can send out in emails and whatever to people.
Thank you. We'd be delighted to share information with you that can help with our recruitment. That would be really welcome. In terms of the handover process, we are aware that not only in midwifery but across the organisation, we have far more handovers of care than we ever have had previously. Partly because staff work shorter shifts than they've done previously, and we have more sick people to hand over. And handover is not just a problem within Nottingham, it's a problem nationally in terms of healthcare. There is a national standard around handover called SBAR, which is a 4-stage handover process, which is the national standard for how we refer and talk to colleagues of the same discipline or across disciplines to be able to describe the situation and the background and the actions and etc. for each of the patients that we talk about. We are in the process of embedding SBAR as the single standard way of talking about any patient from one colleague to another across the organisation, but particularly within the maternity service. So that is an area of particular focus within the improvement work that we're doing at the moment, such that, and it was probably a couple of months ago now, I was at a consultant meeting where they agreed that they wouldn't accept a handover from somebody unless it was in the SBAR format, because whilst SBAR has been the expected up until now, until you take that next step to say you're not talking to me in the right language, people continue to hand over in a less structured way. So that is the level of attention that we're paying to handover, and it is something that we're going to have to continue to do a lot of work on to absolutely embed as the only way that is acceptable.
Thank you. Does anybody have any more questions to ask? No? Oh, Councillor.
Yeah, sorry, rather than a question, a bit of a request with regards to the report if Councillor Saddington's in agreement. Could you have some details with regards to discharge times as well, from when you're discharged from after having your baby and what the circumstances are? Again, talking a bit about personal experiences and experiences of women that have had babies during the pandemic, in that they were actively told they were being discharged earlier than they would. I was told by the two midwives at the bottom of my bed that really ideally I would be kept in longer because I had very low blood pressure after I had the baby and bled quite badly, etc., etc. And my baby was quite poorly, but they felt it was safer that I was at home than in the hospital. That's what I was told. I was then sent home to say that a midwife was going to visit me the next day to check me out and check my scar, and they'd be there at 10 o'clock. Waited for the midwife. I got a phone call at 4 o'clock to say they won't be coming, and could my partner check my scar for me. So I don't know if that's a pandemic thing again, but certainly I would like some extra information with regards to women being discharged from hospital because of a capacity issue. Is that the reason? 2, was it a pandemic thing? But that was the other thing, and I've just read my notes and I apologise, I should have said it earlier, but that was the other thing that the lockdown mums have brought up, that they felt that, 1, they were discharged earlier than they felt comfortable with. And the other thing that they brought up as well is when their child did have a certain condition, again, sorry, my baby failed both his hearing tests before he left the hospital, and not one person contacted me after I left that hospital with regards to the fact that I didn't know whether my child was deaf or not. It was the follow-up after that. I'm not sure where the situation with regards to your maternity services starts and ends, but the thing definitely what was brought up with regards to when they were discharged and that follow-up support afterwards. And as I said, was that to do with the pandemic, or is that something that happens because essentially we had women back in the community and back at home with very little or no support at all? I did say I'd bring that up, so apologies for not. It's my own scrawl. I couldn't even read my own writing. So, yeah, that could.
One of the things I would add is that I can't remember when I did it, but I've reintroduced day 1 because of the pandemic. When a mum goes home, the normal practice would have been the next day a midwife comes in and goes through that plan of care with you and does a formal risk assessment as to when you next need to be seen, because every mum's different. That had stopped during the pandemic, but we became aware that that was creating another set of problems. So we have reinstated that first day visit by a midwife. I was quite insistent that it was by a midwife.
So my follow-up was I wasn't seen by a medical professional for months. So for quite a while, and there's a lot of women out there where that hasn't happened, and their babies haven't been seen or monitored the usual length, head. So my baby had fluid at the back of his brain as well, and it was only because my friend's a GP, and that we spotted the fact that his head had suddenly grown very big. So babies haven't been monitored. They have their length, their weight, their head shape, and this might be another thing to bring back. But I don't know how you work with your colleagues post that, but there is a whole raft of babies and women that haven't had the usual support that they should have. And it is a worry. They're worried about their baby's development. They're worried about their own health and their own recovery. And there's this huge gap. And it's kind of like, you've had your baby during the pandemic. See you later. We're going to move on to the next round of women. So there's this group of 170 women that I have. The reason that they come to this group is because they have nowhere else. They feel they have nowhere else to go. So we run sessions with regards to health and stuff. We don't give them health advice, but just talk as other mums with regards to their babies. So I did want to bring that to light today, whether that's something else that has to be looked at with regards to scrutiny is a different issue, but I did want to raise that discharge child times and the vulnerability of women, their mental health post-pandemic that have had very little or actually no support post having their babies.
I can't answer all those issues now, but I really would like to link with you around your group with some of my team.
I think that would be a very good idea for you to have a one-to-one.
Yeah.
And then all feelings can be aired. Councillor Wilmot.
Sorry to have to come in again, but I just wanted to make something apparent. I know we have on my left here the representative from Health Watch, who are the top. They are the top scrutinising organisation of the NHS and the CCG and so forth. I just would like to hear what this lady's thought about the meeting today, and what will she be scrutinising on these issues, and how will she go about it?
Well, if you don't mind, you can, with pleasure, say what you have thought to the meeting.
Thank you, Chair. I'm here in the scrutiny capacity of scrutinising the services of health and social care, not scrutinising the meeting. So I can't give any feedback on the actual carrying off of the meeting, whatever my personal or professional views might be. I do understand on the whole of the issues that you guys are raising, but and it's not my position to defend NUH here really, but it is the lack of continuity of the committee members, perhaps, that is raising this, because this is not the first time NUH has attended this meeting or raised this matter or presented. So it is difficult, and I say it with huge amount of hesitation because I don't want to be seen as defending NUH, because I do give them a lot of hard time. So I think they're finding this a welcome relief that I am talking on their behalf here. But because this information has been presented, this is probably the third time, Keith, if I'm not wrong, that they are attending here. So what you are saying that you didn't get enough information is probably the reason that they do fall in that gap, where sometimes I come in this meeting and I think I've heard this already in the last meeting. I don't want to hear the same thing. And so they probably as a follow-up have come in here not realizing, or maybe realizing or not, I don't know, I'm not speaking on their behalf, but because I feel personally, I've been here through all the three presentations that they have made, both here at county and city, and a lot of the questions that you are raising are perhaps repetition, but it is always good to have that scrutiny. And I welcome the idea of being drilled down with more information and asking those statistics and those details in the data. I think it has, that would actually give the scrutiny powers more ability to come down. Might I say that it does feel that there is a lot of, everybody, so the main thing is the Ockenden report. The Ockenden report is highlighted. There is a lot what was happening as ongoing, but the Ockenden report has put this in a different ballgame, where the calculation of number of staff that's required is much different capacity, and that's putting pressure nationally. And there are limited number of midwives or limited number of trained doctors that every health authority is competing with. It feels, Keith, today is such a good day for you that I'm talking on your behalf here. So it feels a losing battle that perhaps the service providers are. Going back to what Councillor Welsh has said, I would say that as Health Watch, we are the business of listening to women's voices. So I feel that I need to apologize if you and the lockdown mums are feeling that your voices have not been heard. And I will feed that back to Maternity Voices Partnership, who are supposed to be liaising and who are supposed to be talking to women and capturing the women's voices, but clearly on the ground, women are feeling that their voices are not being. So that's a gap that perhaps even NUH needs to take the lived experience. And we all need to learn much more from the lived experience. That's a wealth of information that's somewhere falling through the gap. Sorry if I'm taking too much time.
Thank you very much for your comments. No more questions, anybody? Good. Well, I have a question for Dr. Girling, please. I think from this meeting, you've got a lot of interested people who would possibly like to pay a visit to Queen's, and I'm one of them. I'm sure my vice chairman would say that he wanted to visit. How many people could visit at once, or could we bring 2 sets of people? How would you suggest we did it, please?
You'd be very welcome to visit both Queen's and or City. I think it's not probably practical to have large numbers of visitors at this time. We could probably
because
take
of COVID.
We are still in hospital. We have not reduced any of our precautions that we've had throughout the COVID period, and I would have thought that we should probably take no more than 3 or 4 people at any one time.
My suggestion was going to be before the October meeting.
Yes.
So that widens it a bit for.
It's impossible to predict what.
Can I leave it that Martin will liaise with you?
Of course.
And see, can I just see if anybody, how many people rather, would be interested in paying a visit to the unit? 1, 2, 3, 4, 5, about 6. Perhaps 2 3s.
I think that would be 2 visits. And would that be to both units or 1 visit to each? As
you think best. I mean, we can go to City if.
So we are 1 maternity unit across 2 sites. May I suggest that we have 3 visitors to one and 3 visitors to the other?
Yeah. Yes. And I'll leave Martin to liaise with you. Is that all right?
Of course.
Thank you very much. Well, can I say thank you to all 3 for coming today and for giving us an insight, because of course we are a new committee, as I mentioned in the beginning. So as Janta has said, a lot of it's been repeated, but that is possibly due to the nature of the fact we've got a brand new committee. And I do feel that Queen's are making a hearty attempt to improve, but it's just in the interim I worry as to how safe it is in the interim. Obviously, you know, Rome wasn't built in a day and it's difficult to do, but it does worry me that in the interim time, how safe people are, because you are under pressure. You're under pressure with COVID, you're under pressure with lack of staff, and it's not all your fault, but it is, the pressure is there. So we look forward to seeing you in October again. And those people who'd like to make a visit will look forward to a visit before. And thank you very much indeed. Let you go and get some lunch now. Thank you.
Councillor Sellington, could we also just give special thanks, because I believe one of you has cancelled your leave to attend today,
It's
which
Carol.
I think is worthy of recognition. And also congratulations on your new post.
Thank you. that we've kept you waiting for a few minutes. I think in the meantime, we're just missing a couple of members, but we will proceed because time is of the essence. So we have Hazel with us today, who's the Associate Director of Strategic Programmes, correct? And we have Laura Stokes, who is the Senior Commissioning Manager for Diabetes. So welcome to you both. And just so that you know, I'm sure Martin's mentioned it, but everybody is new to this committee. I was chairman of Health and Scrutiny about 12 years ago, I think, but a long time ago. Councillor Martin is not new. He was here last time, but everybody else is newly elected. So I think if you could start by giving a brief report of where you're up to, and then we'll take it from there. All right. And you know to put that's it. Yeah. We've had a bit of trouble with that today, but
okay.
You've obviously got the right touch.
Thanks very much for inviting us today. I'm here from I'm Associate Director of Strategic Programmes, as mentioned, for the CCG, but what we're presenting on is the diabetes programme for the ICS. So I just want to confirm that it's wider than commissioning. It's what we are doing around diabetes, the ICS. So we've been asked to present around the impact of COVID and plans going forward. So we have done a brief paper for you, and I'm just going to pull out some key points as part of this. So I think everyone knows that there's two types of diabetes, type 1 and type 2. Type 2 tends to occur later in life and can be controllable through lifestyle factors as well as medication. And type 1 is controlled by insulin. And 85% of people with type 2 diabetes do have another long-term condition. In Nottingham and Nottinghamshire, we have approximately 55,000 people aged 15 and over with type 2 diabetes. And then we have approximately 5,000 with type 1 diabetes. And we're almost certain the number of type 2 diabetes has gone up as a result of COVID and the impact on people's lifestyles. We know within that number of type 2 diabetics that we've got a significant percentage of people that aren't diagnosed. So on top of the 55,000, there will be people that aren't diagnosed who currently have type 2 diabetes, and we've got tends to be more prevalent in men than women, and the prevalence does differ across the county, which we take into consideration when we're looking at how to take forward programs. And it's important to note that there are a number of there are a number of complications associated with diabetes that we have to take into consideration as well, including cardiovascular disease, kidney disease, nerve and eye damage. So what we also consider as part of the program is pre-diabetes. So this is people that aren't yet diabetic and aren't and have been recognized as being pre-diabetic. So we do also offer a program for pre-diabetics, which we'll come to, but that is really important area for us to focus on. And what we do look at also around that is the prevalence in different areas. And we know that in mid-Nottinghamshire, there's a much higher prevalence. So it really is, how do we target that is a specific area. So what you've got in the paper is a breakdown of the different types of services from prevention through to secondary care. But just what I want to highlight was some of the actions that have been taken forward during COVID to support those with diabetes. And this is a particular area also of NHS England, so there have been quite a few things that have been happening nationally. So one is the Nhs Diabetes Advice line, which was a national helpline that was put in place. There's obviously the people that were shielding, which you'll be aware of, and that included those with complex diabetes management. And there was a number of online self-management tools that were made readily available. So pre-COVID, these tools weren't readily available, and they were quickly made available, and that was nationally. Diabetes UK have been extremely active and are a strong support to what we do, and they have done quite a bit that's been COVID specific during the past year. Where possible, diabetes structured education continued, and we had local diabetes groups, so we have local patient groups, and as much as possible they were trying to reach out to newly diagnosed and existing diabetics, and that was both in a one-to-one opportunity and on social media. So there's also, in relation to the NHS Diabetes Prevention Programme, which is mentioned, that's for people who are at risk of diabetes and haven't been diagnosed with diabetes. But that programme was maintained throughout COVID, and we went live with a new provider as well during lockdown. But people were offered 3 choices to access the service, so it was definitely felt to be important that we were able to still offer that as an ongoing service. GP practices have been focused on, so they were seeing people during the pandemic, and those with that obviously need to be seen urgently as well. But what they've been doing as part of the recovery is they've looked at people in relation to red, amber, green. So do they need to be seen and prioritised right away and called in? Do they are they amber, and that's in the next 3 months, and green in the next 6 months? And that's an ongoing process to make sure that people are being prioritised and getting them into the practice as soon as possible. We have what's called diabetes specialist nurses, and they work in the community. They continued to work throughout COVID, and to see those that were individuals that may be having some complications or may be struggling in managing their diabetes. And the secondary care services maintained. So again, if people needed a face-to-face appointment, they could have a face-to-face appointment, and there was also virtual access. So those areas will be continuing, and as well as other work, and we are now looking at a transformation programme. This is strongly supported again nationally, and there's some key requirements for us to move ahead with 2 programmes in particular that I'll mention, ready for the winter, so that we're able to support people not to go into the hospital and to manage their diabetes during the winter. So we've listed there on 4.2 some of the the programs that are business as usual. I think it was just important to note that on the structured education, so there's ongoing structured education programs for type 1 and type 2 diabetes. And so we're obviously evaluating the opportunities that there were with virtual provision of those alongside the face-to-face, and how we recover and get through the waiting list as soon as possible. So those structured education programs are really important going forward. And we have had a couple of additional programs added, national programs during the COVID period. So when we're looking at transformation, it covers the areas of prevention and self-care. For the diabetes prevention programme, as mentioned, we've got a new provider who's living well, taking control, and we've got to increase the uptake of this service over the next year. And we have a real opportunity with Living Well taking control to really make this a community-based service. So they do offer community workers who are reaching out and understanding what the needs are in local communities, and how do we adapt the services accordingly. and we're also looking at what we're also recruiting someone in the CCG to help support the program, because it is fundamental that we are able to reach out to people and get additional uptake in that service. And on the prevention side, we've also increasing the services on weight management. So there's a Tier 2 NHS digital weight management service, and that provides additional Tier 2 services to what's provided through the local authority, and is specific for diabetics. Will be offered in different languages, and there's different programs that people can go on depending on how they feel they would be best supported to lose weight. We're also going to go live with a low-calorie diet program specific for diabetics in January. So we're going through a process to procure the provider for that service, and that again is another really good opportunity, and that will definitely be focused at specific areas where there's the highest level of need. That low-calorie diet program is currently offered in Basildon and has proven to be successful. So in the hospital, what we are piloting at the moment, and what we look at expanding on, is how do we provide support to people who are in the hospital for elective care, or if they're in for another long-term condition and their diabetes management is, or they don't have good diabetes management or control of their condition. We know that a significant number of surgeries are cancelled or postponed due to poor management of diabetes, and this is often identified right before the point that person is going for surgery. And so what we've implemented is a pre-op service where that individuals will be reviewed whilst they're on the waiting list to see what their diabetes management is like, and where they may need some support to get better diabetes management, then that will be provided while they're on the waiting list, and also at the point that they're referred. And so that should reduce people's waiting time, but also it helps with recovery, because we know that poor diabetes control does increase the risk of post-op complications. And this service will also see patients in the hospital post-op to make sure that they have a plan when they're discharged from hospital to manage their diabetes. So we'll be looking at how we can expand that further. And then the other areas around foot care teams. So we do have diabetes foot services at the moment, but it's how do we improve on the foot care teams to make them more accessible. Foot ulcers are a really significant risk with diabetics. We know that we probably have approximately 1,300 diabetics with foot ulcers in Nottinghamshire at any given time. And there is a real severe long-term effect on quality of life, and it can lead to lengthy spells in hospital and ultimately amputation. And we are an outlier for amputations. So the new program is really looking at how do we more effectively combine the community services with the secondary care services and ensure that people are seen at the right place at the right time. And also have a strong element around patient education, and address any gaps that are there. So we'll be moving ahead with that at pace and have the funding to support it. And then further area we're looking at is increased improvement of the diabetes treatment targets in primary care. So there's 8 care processes in NICE, or 9 care processes in NICE guidance, and 3 treatment targets. And the care processes are around the HbA1c, which is your glycemic levels. It's around cholesterol, it could be BMI, kidney function, smoking. So it's a breadth of key processes that the primary care are to check individuals on an annual basis, and then reaching the three treatment targets. So what we're looking at is what we're calling a combined primary and community care model, which is supporting the GP practices and the diabetic specialist nurses to hold combined clinics and to offer increased skills in primary care to really support individuals with their diabetes and to provide that extra specialist support. So we do see that with that, alongside the secondary care services, will provide robust services for increased care of diabetics. So in conclusion, there was a significant activity that continued during COVID, but without a doubt, there's increased risk of people moving from pre-diabetic to diabetic, and so it's how do we reach out to those people as soon as possible, and also how do we support people with their diabetes management and continue with what we've learned during COVID around access to structured education and how people can best be supported through those programs.
Thank you. Thank you very much. Does Laura have anything to say, or are you taking questions? You're right, that's fine. Has anybody got any questions, please? Thank you for your presentation. Yes, Ajanta. Yes?
Thank you, Chair. Thank you, Hazel, for presentation. Can I just start off by saying that the presentation does lack a lot of details. It's very ambitious and aspirational plan, but we have no data, no timeline, no exact details of actual implementation plan. So while you're saying that, you know, there's going to be an education program or, for instance, living well, taking control, it's very difficult to scrutinize this if there isn't any actual data or actual timeline. What are we scrutinizing against? That said, can I just ask some specific questions? The education process, at the moment, the evidence that we have at HealthWatch is that the diabetes education, is it mandatory or is it just depends on the patient's choice? We have information that patients are not given information that there is an education that they would benefit from. It's a process of postcode lottery, depends on if the GP has taken the initiative of informing the patient. So is the CCG doing anything about it? That's the first one, education. The second one is on the low-calorie diet program. You're saying that it is started on Bassett Law. Can you give us any more information as to why it is not starting or when it is starting anywhere else, the timeline, and what will be the recruitment criteria? Will the patient actually be given proper education in order to highlight that it is beneficial for them, or is it just patient choice? My third question is, again, the living well, taking control. What are the criteria to access it? And is that again a postcode lottery, that if the patient is aware and if they are demanding, then they are getting? Those who are not demanding, areas of deprivation, how do they access it? My final question is on PFU, the patient-initiated follow-up. This annual diabetes check that you're talking, the annual model, is that going to move to patient-initiated follow-up, or is it still going to continue that the GP will write to the patient? Thank you.
So if I start by answering some of the questions, and I'll defer to Laura as well, so we'll go through each one in order. I think as far as the detail, we were asked to bring the paper around what had happened during COVID and what are our plans. So we haven't brought it as we wanted to propose to you services that we're looking at. So I think there's two different elements. So absolutely, at the point that we were, if we need to consult with you on these as significant changes, when we would have brought more detail. So I think we tried to structure it based on what we were asked to bring. On the, so absolutely, we can do a, I don't know, Martin, if it'd be appropriate, we can write a paper that gives you more detail around implementation and things like that. So that's not a problem. If we maybe work with Martin around what detail you'd like. And
please do.
So on the, if I start with the structured education and a postcode lottery, we do offer the same structured education for type 1 and type 2 diabetes across Nottinghamshire. And what we are looking at is a role itself that will help to promote the service and work with different communities, so that we do have a role internally. But the providers themselves do a lot of reaching out, and I think it's always a question of how can we better engage and make sure that people are aware of these programs. And we're always open to other ideas, but absolutely it's something that we are continually looking at how we can improve on. And I'll just ask Laura if there's anything more.
To answer your question about whether it's mandatory or patient choice, every patient that's newly diagnosed with diabetes should be referred within 12 months of diagnosis to patient education, but it isn't mandatory. But it is a key performance indicator that is collected within the National Diabetes Audit. So we do scrutinise that data on an annual basis, and we know there is variation amongst our GP practices across the ICS. And as Hazel mentioned, by recruiting a dedicated post, we hope to start to tackle some of that variation and understand some of those barriers going forward, not just for those that are diagnosed with diabetes, but for people that are pre-diabetic as well, and how we ensure that access is equitable.
Thank you. Councillor McGrath.
Oh, there's just a few.
Oh, sorry.
There's just a few more. Do you want me to?
Oh, sorry. My apologies. My sincere apologies.
No, you're right. So on the low-calorie diet, the timeline is we go out to procurement in September with implementation in January. We're still working. We're just actually notified last week that we've been approved. Our expression of interest has been approved. So things like recruitment criteria, all that is still to be worked through. We have 500 places, so it will be very much targeted to high risk and specific communities where we know it's high risk. And there will be a program around how do we make sure that we are fully inclusive and recruit people as effectively as we can. So that one, there's more information to come on that, but it will absolutely be supportive for those at the highest risk and targeted. And then with Living Well taking control, I'd be concerned if it's being described as postcode lottery. It is offered equally across Nottinghamshire. Again, there's some work to do with specific GP practices, but the Living Well taking control, as mentioned, are extremely proactive, and we do see that there is a lot of opportunity to help widen access to the service. Again, if I defer to Laura, who's got the expertise in the detail.
Just in terms of criteria, so Living Well taking control is available to adults between the ages 18 and 79 years. Those that aren't pregnant, no diabetic, obviously, diagnosis, and moderate or high risk of type 2. We have expanded our referral pathways actually in light of COVID. So originally the main method of referral will be through primary care, but in response to COVID we have established a self-referral route where patients can access the Know Your Risk tool either through the Diabetes UK website or through the Living Well Taking Control local platform itself. And actually we have seen a large number of referrals generated over the last year with our previous provider and now with Living Well Taking Control. But we do know that there is room to improve. As Hazel said, we came into contract beginning of December with Living Well Taking Control. and we've really run with the comms and engagement with local communities, and we've hosted a series of online events for patients and for practitioners to understand more about the programme. And Living Well Taking Control have recruited educators that are from local communities that do speak multiple languages. They offer sessions Monday to Sunday, evening, morning, afternoon. Actually, quite interestingly, during COVID, we thought the Saturday, Sunday sessions might be quite popular. Turns out, because people are working from home, actually it's more convenient for them to access during their lunch times. But they're very flexible in their approach, willing to work with the local health community to make sure that it is accessible. And I would say we're doing really well with our referral profile at the moment against our national targets, but there's definitely room to improve, and lots of opportunities that are coming up over the next few weeks. Actually, it might be an opportune time to say that it's Diabetes Awareness Week next week, and we are actually hosting a patient awareness event online with Living Well Taking Control. So if you would like to share any information within your local communities, that would be fab.
Thank you. Where do we? Councillor Mulgrew. Oh, did you want to come back?
Did you have any information on the PFO? On the patient-initiated follow-up, is diabetes annual checkup going to move into patient-initiated follow-up, or it is going to be an annual review written by the GP letter? Do you have any information on that?
At the moment, it's an annual review initiated by the GPs, but we can certainly look into that further. So the key element around diabetes is absolutely around self-management, and so that would be supported by patient follow-ups, and that has been encouraged obviously through COVID and people are being more aware of their condition and the support they need, but we can look into that more formally.
Okay. Right, I'll go to Councillor McGrath.
Thank you, Chair. My question is just to Hazel, because the lady from Health Watch asked quite a few of them. You know, most of these diseases are obviously picked up when you go for, as I call it, your well man check, aren't they? Well, I went with mine on the railway from when I was 40. Is there any way we can bring that down lower, for one? Because it seems to be 50. And just a question, I'm not being rude here, do they have well women checks? Because I know my wife's 56 and she's never been notified by the GP to come and check, you know, your blood pressure, your BMI and this, that and the other. But obviously I was on the railway from a young age, but we used to always get our medicals at 40. Obviously your eyesight were tested, your kidney function and everything. Since I'm a bit older now, I'm 60, right? But from 50, my GP always done it. Now, obviously through COVID, it's been different because obviously they haven't had the time. But I just wondered if there's any plan around that, Hazel, as well. Thank you.
So yes, there are health checks in place, and those are commissioned in effect by public health with the GP practices. There are health checks for males and females, and I don't know what the age is. I think, yeah. But so there is a whole program around health checks, but I haven't got all the detail to hand. But happy to send that through. But I know that there's often, we're always trying to promote those health checks and people to uptake the health checks, and equally working with the GP practices on how we can be more effective around increasing the uptake around health checks.
Hazel, it might be an idea then, sorry. Might be an idea if perhaps members of the committee could have the list of the GPs, because I can assure you there isn't one where I am. I get my well man check, I'll tell you that now, because I'm over that age. But my wife and a number of people have not. So I'm not calling me GP. I won't do anything like that. It's not right. But it's obviously not being promoted out there. And you telling me that has surprised me a little. So I don't mean it that I'm not being detrimental, but it surprised me that it's supposed to be out there. So if we could have a list of the GPs apparently that run these schemes, it might be an idea. And then if they don't, early detection's easy, them, isn't it? It's not easy, sorry, but people are aware.
Yeah, so they all offer it. It's commissioned by Public Health, but what it can do is just get more details for the scheme for you and how it's promoted, and always we're open to ideas on what more we can do, so any ideas that you have as well around that would be useful. But yeah, absolutely, can get more information.
Thank you, Councillor Martin.
Thank you, Chair. Yeah, there's a couple of things really. One is I think it would help members of this committee to have a demographic map to show if there's any link to deprivation levels related to type 2, diabetes. As far as Councillor McGrath's question is, this has been an issue for GP practices for quite some time, and it's quite interesting that earlier on you picked up on the irregularity of promotion of diabetes treatments. It varies from practice to practice, because at the end of the day, GP surgeries are like autonomous businesses in their own right, and it's up to them how they run their surgeries. But we've had a major inconsistency for over 5 years on well-being checks. They're not called well woman or well man anymore, they're called well-being, right? So it's up to the doctors' surgeries to proactively send out the messages to their local residents to invite them for a well-being check. But it's a bit like having an MOT, and when the doctors are under the cosh and they're very stressed and they're unable to cover the actual resident base that they've already got, having a well-being check highlights issues with other. So it's a bit like job creation scheme, and the cost of the well-being check, I think each GP gets £25 for doing one, and it's like asking for work. So that's why they don't promote it, and that's why there's a major inconsistency across the county, and it's been like that for a long time, because the doctors are already busy and they don't want to invite more work. So that's why there's an inconsistency. But there should be, and probably we ought to put it onto the work programme, because a review of which doctors GP practices do promote the well-being checks, and those that don't will be clearly highlighted because they're all paid for it. So we will have the statistics available across the county where they're being carried out and where they're not. And it is a crucial issue because it picks up many things. I mean, I believed it was 50, but if you're saying it's 44, then that's gone down. I thought it was 50. Yeah, right. But it also highlights a lot of other issues for people that they don't know they've got. And that is a major thing. It's a bit like a screening programme, really, that's not happening because the doctors are already too busy, and it's not enough. They feel they're not getting paid enough to do it. And obviously, Dr. John Doddy was on the Health Scrutiny Committee before, and we had a great debate about it. And we tried to bring it back to the Health Scrutiny, but we just ran out of time. And I think it's something that we ought to review because it's a crucial thing, and it helps these people. Social media, and I mean, you're saying this you've got this company that we presumably the county council pay under a contract to do what do you call it, living well. Yeah. See, I mean, we've never heard of that. I've never heard of that. And like we are the social outlet for each part of the county, all over it. So, but please don't do what all NHS staff do, and they send this like flat, boring thing that you can't use on Facebook. If you're going to use something to promote your service through Facebook, it needs to be something that catches their eye, not that turns them off after 3 seconds. Because that's what a lot of NHS stuff does. It's very flat and boring. It doesn't interest anybody, even if they've got it. It just like, it's not interesting. So it's about your design and how you promote that service, because we will do it. I mean, Mental Health Week is another major issue that we promote through the county council's Facebook page and Twitter. And we can help you to deal with that, but it has to be inviting. It can't be boring, because people just switch off from it. They won't engage. And that's another part of the problem.
I agree. And what we're trying to do as patients progress through the programme is collate together a series of case studies, videos written so that they can be shared widely. And as Hazel mentioned as well, as participants complete the programme within the locality areas, we will recruit local volunteer champions to work with those communities, to reach out to communities in different ways, you know, not just social media, but through the community groups, because there's a whole, you know, there's a wealth of opportunity in the community that we're probably not touching. But certainly, if you let us know which routes that we can, how we access sharing that information, whether it's reshare through Martin, but whatever's easiest.
Chair, the County Council's got its own Facebook page and Twitter and its own accounts, so you can share it through that, and then we could probably pick it up, or you could actually send an email out with a link to the through Martin to the committee, you know. But it's got to be inviting, it's got to be interesting, and it's got to be short and brief and punchy and to the point, because a lot of NHS stuff is just flat boring.
One of the things that the Diabetes Prevention Programme does do well is it does provide resources in multiple languages, whereas I know some other programmes perhaps haven't done that, but with this new contract, that was absolutely a must do, so we can provide it in multiple languages as well.
Okay, thank you.
You mentioned about type 2 and deprivation, and we absolutely see a higher rate of type 2 diabetes and the pre-diabetes as well in areas of deprivation. We have got a comprehensive population health management pack, which really shows us where the areas of prevalence by the different areas and deprivation. So that is information that we do use in looking at how we target the services, and happy to share any of that if you'd be interested.
Thank you. Did you want to come back?
Yeah, I think that, I think that's actually very relevant to us, because we're all across the county, right? And people don't relate deprivation levels to diabetes. And a lot of these councillors have never been on health scrutiny before and wouldn't have had a clue that that is an issue, and it really is. And a deprivation map would clearly show that.
Councillor Gowland.
Thank you. Just picking up on that point, and echo everything that's been said before. You know, you're talking about patients and GP surgeries, but of course these are not patients by definition. If it's pre-diabetes, you want to reach the community. And I just wonder what the crossover is with the mental health service, because presumably quite a lot of mental health patients may have pre-diabetes risk factors, I'd assume. But I wondered, I was particularly concerned about the amputation rates. And I wonder if you could just be precise about what the amputation rates are here and nationally. And also I was wondering about youth diabetes services, presumably, hopefully, largely for type 1 diabetes. And what provision is provided, what's provided for young people, and including protecting their mental health.
Who's going to answer that one?
I haven't got the amputation rates at the top of my head, but we absolutely have that that detail that we can provide to you, and we can do that as part of the information more around the service. But yeah, we've got that that detail. And then youth diabetes services. There are youth diabetes services. Again, we're looking at that nationally, how that develops. There's a youth diabetes network, and it's really just how we take that forward. So there isn't anything as part of the transformation program, but it is an area that we're picking up as a future area of focus. And then the link to mental health. Do you have anything more you want to add on that? Not necessarily around youth, but
with regards to mental health, so we work quite closely with our local IAP teams who the wellbeing practitioners are trained in long-term conditions management, so they will work with our local diabetes specialists and vice versa on mental health and diabetes related issues. So there is that link, and we have a wealth of health education platforms that they can access across teams, and there will be that sort of cross referral route as well. For people that are diagnosed with diabetes, there is clinical psychology within the secondary care trusts, and we are actually just about to start a mindfulness pilot with NUH for people that have been newly prescribed insulin over the last year, particularly given the back of the COVID pandemic, that might be struggling with anxiety and depression. So we'll obviously evaluate the success of that pilot and see if mindfulness is something that we will roll out going forward.
Councillor Barney.
Yeah, so I admit a slight vested interest here in that my daughter is a type 1 diabetic. She was diagnosed 3 years ago. And I'd just like to, on the back of Councillor Golan's comment about mental health, just commend any future policy, any future direction, the support of professional psychologists and counselling teams is first rate and has been with my daughter. And I think that's been absolutely vital as she's gone on her diabetic journey into this whole confusing and crazy world of up and down type 1. So I'd really endorse that be at the forefront, particularly with all the other stresses. I know everybody's talking about mental health, but I think with diabetes, with type 1, I think it's absolutely critical as part of that journey. I've got a couple of points questions as well I wanted to ask. Obviously, with type 1 diabetes, you go on a very rapid learning curve. The training happens day one, really, because if you don't sort it out, you're going to be in a mess. I just wanted to be reassured, really, that for everybody that's been diagnosed across all age groups through these COVID times, that training has been there, that they've had the same level of service as they would have had outside of COVID.
Yeah, so the for type 1s, they would be accessing the services when they're first diagnosed through secondary care, and that has absolutely been available. But then there's also the structured education programs. And there we have specific programs for type 1 diabetics and type 2 diabetics. So as Laura mentioned earlier, people should be referred into those services, and we do. And the secondary care for type 1s, absolutely, would they provide the service, so they would be referring into it. And they did go virtual, obviously, during COVID, and so now it's looking at restarting the face-to-face. People were asked that were on the waiting list whether they would like to access the virtual or wait for a face-to-face session based on how they felt they'd best engage with it. So we're just looking at how we can get the face-to-face, where those are starting now, and make sure that the people are accessing the service. So they have been available as much as possible, and we are looking at how we can recover them as quickly as possible as well within the resources and what other options there might be.
Fantastic. I've got a second question, if I'm allowed, and it cuts across type 1 and type 2 diabetes. Is there any evidence to suggest that people's diabetes control and care has worsened through lockdown, so with people's inability to get GP services in the same way they had before? Is there any data collected that shows HP and A1C rates have worsened and daily care has lessened as a result of lockdown and all the COVID situation? And if there has, is there a time bomb that we're sitting on here where all this is going to come back and bite us?
So there is no absolute direct evidence, but yes, along with other long-term conditions, there is evidence that there's no direct evidence that the conditions have worsened, but there is evidence that people have things have worsened through not being able to access the services. Our experience through our diabetes steering group is that they are seeing people with higher HbA1cs, that people have struggled to control their diabetes, people have put on weight. So we are working through with our services what the impact will be, but absolutely there is the risk that there is a time bomb. And as I mentioned, you know, we already knew that we had a certain portion of people walking around with diabetes and not diagnosed, and that's where they may not be accessing services or haven't seen that, or they themselves aren't accessing services. So it was there pre-COVID and it will have worsened. So it is absolutely essential that we get these people into the practices and we get people to have their reviews, and that's where also the prioritising by red, amber, green is helping to support this. But so there is the focus on these patients. But
I would just add that I think what we'll probably see when we receive the latest national diabetes audit, when we look at the 8 care processes and 3 treatment targets, we'll probably see through that data that's collected through GP systems, probably a decrease in the number of people that have received those checks and achieved all those recommended targets. I know that at the regional level, they will be doing deep dives across the different systems to understand how COVID has impacted us over the last year.
I think, and just to add to that, it absolutely is a key priority for NHS England, and that's where we are required to, and we're on train to implement more, make sure we progress with the foot treatment and the inpatient services pre-winter, so that we're have that support there for people, and also the push to get more people through the diabetes prevention programme as well.
Thank you. Councillor Wilmot.
Oh, thank you, Chair. I'm just looking at the statistics you just put out. 55,000 people. Is that in Nottinghamshire that got diabetes? Obviously, you're absolutely right. There's many more probably got the symptoms, but I've not been able to access a system to be able to find out. I just wondered what you were doing extra on that issue in doctors' surgeries or any developing areas where people are beginning to, where new housing estates are being presented and so forth. And the other one was about, I've always been on about, over the past 30 years, prevention and self-care. Prevention is a thing that needs to be at the top of everybody's list because of the situation. If you can prevent it, all the effort that the doctors have to go through and so forth doesn't have to happen. And I just wondered what you were actually doing to promote prevention issues, you know, all these smoking and obesity and heavy alcohol consumers. Have you been getting involved with community events, large community events, or because and schools are a really good issue to get involved with schools because it's the parents they talk to, you know, who have got the problem very often. I just wondered, and also major retailers like Tesco's and things like that, where there's in Hucknell, in Bulwell and surrounding areas, there's over 1,000 people that are working there. You know, they're the sort of issues where you can get the information out and you might be able to help in preventing some of the issues. I just wondered if you were doing anything in that situation. Some seminars, talking to Age UK, of course, loads of elderly people get these problems, and Age UK are good at getting information out to the people. I just wondered if you were doing anything in that area.
Yeah, so that's a really big question, and I think with the key element going forward is obviously how we work more closely with the local authorities, and that's what we're looking at the ICS. You'll know that through the local authorities you have programs like Your Health, Your Way, and they are really around all around prevention and improving lifestyle factors. And then what we need to look at is these specific programs that we are offering through the health service. Like I mentioned, that we've got now the opportunity for NHS Tier 2 weight management service that sits alongside the wider Tier 2. So for weight management services, there's 3 tiers. The Local Authorities Commission Tier 2, and Health Attendant Commission Tier 3. What we now have this year as an example is the opportunity to really broaden out the Tier 2 services. We're not looking at it as what does Local Authority Commission, what does Health Commission, but what can we provide in entirety around weight management services, and how do we target it to the need. So I think there's real opportunity in going forwards, and again working as the integrated care service around prevention and working together on how we promote all these services. So we do, as mentioned in relation to this paper in diabetes, we do try and reach out as much as possible through community events, we held a virtual session with Diabetes UK and the CVS in March around prevention for diabetes, and that did show that there was interest. And so we are always looking for opportunities, but I think it's how do we do this more effectively with the local authorities and really changing behaviour. And it fits to the health check discussion as well. So it's all part of a broader piece around how I think equally we do reach out to our communities around this.
Thank you.
How are you actually promoting that service? We're not seeing it in my sector. I just wondered, what issues I get involved in to look at discussion.
Yes, so the self-referral pathway for the Diabetes Prevention Programme, as I said, was introduced post-COVID, recognising that not so many patients would turn up at GP practices where they would opportunistically identify someone as pre-diabetic. Obviously, with pre-diabetes, you don't tend to have any symptoms. So it's through other checks like your NHS health check, or opportunistically go to the GP for something else that you tend to find out you've got pre-diabetes. So the self-referral pathway was introduced. It has been promoted via usual social media channels. So we have a local website for Living Well Taking Control that's not Nottinghamshire relevant. Diabetes UK, the Know Your Risk tool is embedded within Diabetes UK, and as they have been fiercely promoting all of the tools available over throughout the pandemic. We have, in the last 6 months since we started Living Well Taking Control, hosted a series of webinars, as Hazel said, one with the CVS where more than 100 people attended. So we were promoting the service self-referral pathway through that route. We have established links with local employment sectors. So where any opportunity that we get to engage with patient or healthcare professionals, we are promoting all the referral pathways that are available. I think going forward, we will do some dedicated work around the self-referral route to maintain momentum. But what I would say is the self-referral pathway is subject to NHS England extending that. So we won't know how long that will be in place. At the moment, it's in place until I think the end of September.
Thank you. Any more questions? Councillor Barney.
Yeah, our friend from Healthwatch mentioned postcode lottery. And I'm not commenting on whether that's the case across Nottinghamshire as a county itself, I don't know, but it is the case across the country that diabetes services and the technology surrounding diabetes management and life care does vary enormously. I heard recently that Dexicon, for example, is being funded up in Leeds. And I just wondered, is there a way that residents of Nottinghamshire can compare what our trust is funding in terms of the technologies available for diabetes care, to compare that with other trusts across the country?
I don't know. That's a good question. And there's quite a bit of technology around, you know, I think Flash Libra was the one that, that it has been, you know, looked at in relation to postcode lottery. And we are looking at how we do provide those different services, or that technology, or those means of managing diabetes. So it is something that we are always looking at. How do we expand what we are doing? But I'm not sure about secondary care, but we can ask one of our consultants about that.
I think it's an evolving area. So I think I think they're starting to capture some of that data through the national audit. So there's a paediatric audit, and then there's the National Diabetes Core audit. So I think as we become better at prescribing this technology, we'll probably see it reflected in our national audits. It's certainly data that we can capture through local requests. And just to say that obviously CGM and Flash, they are national priorities. And locally, we do have plans underway to expand the criteria further, so we are reaching more people.
Thank you. Happy?
No, I was just going to thank you very much. I was just going to make the comment. Obviously, these technologies make such a difference, and just in our short journey as a family's exposure over 3 years, we've seen that technology improve. But I know these technologies are so expensive. But for the 5,000 people listed here with type 1 diabetes, we'd want to, as a council, to ensure that we were getting the very best we could for the residents of Nottingham in terms of that respect, because it makes daily life so much more bearable and easy, as you well know. Thank you.
I just said that's great to hear. We did see some national data a couple of months ago, actually, which showed that Nottinghamshire are in the top 5 in the country for Flash Libra access, which is a great start, given that it's only been in place the last couple of years. So real positive.
Well, with that, thank you very much. Thank you very much for coming today and for updating members on where we are at the moment. Can I ask that you do send the information to Martin as soon as possible so that it can be distributed? And can I ask, please, that we see you in 6 months' time with a further update, possibly as to the increases also that you've seen in diabetes as we emerge from COVID, assuming we emerge. But if you could give us some idea of whether people have reported that they have diabetes, and Martin will be in touch with you. So thank you very much, ladies.
I think also just to offer, I don't know if it's appropriate or not, but if with it being new committee members, if anyone has any questions and they want to or for us to discuss anything in more detail, we'd be happy to, obviously linking in through Martin.
That's very kind of you. Thank you. Competing against that noise out there now. Thank you very much. Now moving on to the work programme. Has everybody got a copy of the work programme at the back? Right, just to mention, thank you ladies, bye-bye. Right, just to mention one or two things. Firstly, we're at 1:30. We've been here 3 hours. As Martin did say to those people who came to the scrutiny presentation this morning, it is a meeting that does extend. So please can I ask you to be prepared for that, and any appointments you have later to make sure that they go outside of this time. And you'll see why in a minute. July, as I've mentioned before, we go with what the previous committee suggested, and Martin has the various invitees organised for that meeting. But I think I'm correct in saying that the allergies in children is going to be rescheduled at a later date, because following our last council meeting, Councillor Guilfoyle came to me and asked if we could look at the mental health proposals that are going ahead in Bassetlaw. We couldn't have it on this meeting because the agendas had already gone out, but this is of concern to the people in the northern area, and I understand from Councillor Guilfoyle that they are starting to move their services across to King's Mill, and they were told to wait until it was discussed here. So I think it is a matter of urgency that we get it on the next agenda, and something will give way, and that will be the allergies in children. So on the next agenda, we've also got presentation from the East Midlands Ambulance Service, and we've also got on the agenda tomorrow's NUH, and those items in themselves are going to be quite busy. So can I suggest that we are prepared? That's all I can say. Now, moving on from there, we can now plan our work programme, because these are items that were planned previously. And I would like to make two suggestions, which I think probably will be of interest to every member and every member in the council. One is that we look at primary care and see what on earth is going wrong in primary care. And secondly, mental health, because I wouldn't like to be the committee that's left behind in this, because it is such a big issue. But I do feel that children have suffered through being out of school. Middle-aged, dare I say, adults have missed seeing their friends, having coffee with them, lunch with them, and goodness knows what, and the elderly have missed out. So each category has had different problems. And I do know it as fact that they are given tablets when they go to the doctor and told just to go away and take the tablets and it'll all go away because it's actually a bit of depression or something. That is not on. Everybody has to be treated separately. And I think we need to bring a lot of people in to have a look and hear from them as to how this problem is going to be tackled before it gets out of hand. So if people are in agreement, that is what I'd like to put forward. Yes, David.
Yes, Chair. As part of the primary care review, we ought to be incorporating into that, asking the CCG to look at primary care GP practice provision. Absolutely. Because of like places like that are potentially developing, like Hucknall, the 4,000 new homes there. Yeah. We really ought to be looking across the county
how they're going to
if they've got a strategy in place to,
which they really should have from the 106 agreements.
Yeah, each borough and district has got
everybody's got the problem.
Local plans and
people
building.
Can't get into surgeries for appointments, and you know we've heard it today that people just can't get appointments, and I think we need to know how they're going to address it. Councillor Wilmot.
With what you just said there, Chair, probably we ought to be scrutinising the surgeries.
That's it.
Totally.
That's
from
it.
Top to bottom. And
it will be done, won't it, Martin?
And of course,
it is going to be big. It's going to be drilling down, and it's going to be big.
Making sure that we get all the information from how many each surgery patients and so forth. And of course, the statistics from a lot of the other scheduled items that are on this agenda over the next few months. We want more statistics so we can see what's happening in that service.
But we will do it, I promise you. Yeah, well, we're going to have it correctly written. Yeah. 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 Well, I think our first question to the primary care is when are we able to go and see a doctor? You know, we're in here now. Why can't we see a doctor? you know, everything is now going to be done by telephone, it would seem.
Having seen some of the statistics already, you go to different surgeries and it's 4 weeks for some, 3 weeks for others.
Yeah.
Oh, you'll be all right. You'll be in tomorrow.
Councillor Gowland. It will go, yeah. Yeah. I would expect this to last 4 months and be carried over each month with something smaller put in, so we've got a difference. One thing I do want to say is I do want the whole of the committee to be involved. I've sat on committees myself where if I haven't done something, you can very easily feel that you're not involved with the committee. I'd like everybody to be involved, hence the reason I asked if you would like to go and see the maternity unit at Queen's. There is no doubt about it that when we start mental health, we will go into some mental health places so that we can look at the type of places that people are taken into and how that affects them. And the other thing is we do have, Martin can explain better than I, but we do have quality accounts that come to this committee, and we are supposed to write a summary on what we think is within the account. And I believe Healthwatch do it too. So the reports are to come from this committee. I have to say, since the election, our very abled Vice Chairman has written 2 of these reports, and they've been excellent, truly excellent. They haven't been very long, Matt, have they? They've only been half to a full page A4, not just commenting on things and giving and thanking them for giving us the opportunity to make the comments. And we have one which has to be, Martin's going to have to tell you because I don't have it with me. It has to be done fairly soon, and it is on the Sherwood Forest hospitals. And I wondered if other members of the committee, other than Matt, who might have an interest in the Sherwood Forest Hospital, would like to do it. You're one for a start. I saw you packing your bag. I was hoping you weren't going to nip off.
So, Councillor Martin, you'd be interested in providing? Okay.
Martin will guide you on it. Yeah, although Councillor John Doddy isn't on this committee and he's not a part of it, he does want us to work. If I say partnership, that's wrong, because at the end of the day, we have to scrutinise him. But he would like to feel that it's a wider remit of people, and to include him, which I have no objection to at all. And he wants to come on some of the visits, and I think that would be very useful for him to do so. So, you know, he may be involved. And we really want to, his words to me were, let's make it an exciting committee. And that's what I want to do. That, you know, there will be long drawn out meetings, but let's make them exciting. Let's find that we make some progress, and let's have a look around at the units and go out and visit. Pardon? Well-being. Yes, Mike.
Thank you. Just something to bear in mind. We've obviously got the issues of long COVID that have been talked about quite readily. And I know I've just had a look through the itinerary and I can't sort of find anything, apart from the allergies in children, of something that's focused around respiratory
That probably wouldn't have been on, because when they were planning this,
Yeah.
you know, they knew they were coming up to an election. But I tell you what we could do on those days when we start doing mental health and primary care. They're going to be month after month for a long time, because we're going to have all different people back. But it would be quite nice to have a small one somewhere in between the two big ones, and long COVID and its effects could be one of them. You know, make it that we've got the big primary care and all the doctors' surgeries and the problems that we've got with them, and we've got the mental health, which is going to be huge when we start drilling down. And when we want a light bit of relief, we'll find a small one, and COVID effects could be one of them. Yes, yeah. Yeah, everywhere. Right through. No, it's the Bassett Law Mental Hospital that's causing the problem with the Bassett Law members, and we must look at it as quickly as we can. Does anybody want to help David with this report for Kingsmill? Are you quite happy to do it on your own? Okay, so can you liaise with Martin on that? Thank you so much for coming today. You're very welcome to our meetings.
Thank you, Chair. That wasn't my offer trying to help David.
Oh, well, I'm sure he'll take you up on the offer. I'm going to leave you two to discuss that.
No, it wasn't an offer to help Martin.
Oh, I thought it was.
No. The quality accounts from HealthWatch for Sherwood as well as NUH. I was going to go to the previous point that when we are asking people for presentation, can we please request them to give evidence with statistics and data, because coming here and just saying, that this is our plan, as ambitious as it sounds,
absolutely,
this is exactly what happens, that they come in and then they say that our brief hasn't been to provide data. So today with diabetes, we have no further information of exactly how many are able to do self-referral. My hunch is that the self-referral is perhaps got a huge backlog on this, whatever, living well, taking control, but we haven't got those data. So if we don't have data, I feel that we can't scrutinize.
It's worthless. Absolutely. I couldn't agree more. So thank you very much, everybody. I hope you haven't found it too long. I hope you found it interesting. I look forward to seeing you all whenever we see again. July the 13th. We'll nearly be ready to break up for the summer. Everybody be in good mood. Thank you, everybody, for your participation in the meeting. I think it was a good meeting. Pardon?